Corridor Gida, Croeso e Bwrdd Iechyd Prifysgol and Aneurin Bevan. Welcome to the meeting of the Aneurin Bevan Health Board. And I welcome those guests who are observing. I do hope you find this helpful and informative. Today's meeting will of course be recorded and published on the Health Board's website for viewing following the conclusion of the meeting. I have a number of people to welcome. Paul Solway, the Director of Digital, has joined us, and Martin Blake, I'm very pleased to see, who I've never seen you in the flesh before, who is our new independent member for the third sector, and welcome to you both. And I hope that you enjoy your period of employment with us. I should particularly like to congratulate Louise on the award, fantastic, of the UK Rep of the Year for the Chartered Society of Physiotherapy. Excellent, really, really good. Also, that's a good achievement, that.
Thank you.
I'd also like to welcome Gemma, the Regional Director for Llais, Tracy Beale from Audit Wales, and George will be joining us for item 5.2 as the Chairman of the Partnership Council. We have apologies for absence from James Calvert. Are there any declarations of interest for any of the items on the agenda? No, thank you. Might I take the draft minutes of the meeting held on the 24th of May? Are they a correct record? Yep.
Yep.
We've also included a summary of the board business that was held in committee on the 24th for noting. The action log, please, Rani.
Thanks, Chair. So the action log includes 3 actions from previous meetings. 2 actions are scheduled to come forward to the board in September, and the 3rd action relates to an update on WCCIS, which is included on today's agenda, item 5.6.
Thank you. Thank you very much. So item 1.7, the sealed documents and chairs actions. I would ask you to note these and ratify if you think appropriate, please. Are you all happy with that? I do try and take as little chairs action as possible because I think it's important that we share the actioning of activities here. My report, it's quite short. Apart from the plethora of meetings that I have had on an individual basis and the visits that I've undertaken, I've attended and chaired 2 of the meetings of the health organisation chairs, where we've been discussing governance, particularly that relating to the accelerated cluster development and RPB governance. And as you will know, I've asked for a governance review into the Regional Partnership Board to be undertaken immediately, and that is ongoing at the moment. We also discussed the consequences of the financial position within Wales and the consequences in terms of service reconfiguration. We have agreed a set of criteria against which we will adjudge the proposals that come forward for service reconfiguration to make sure that they are efficacious for the population and ethically sound. So that has been agreed. We have also had a very interesting presentation from Public Health Wales on diabetes, and we know that the chairs will have as a goal and objective the reduction of diabetes and the consequences of weight management within their objectives for the next 5 years. So that presentation was very helpful indeed. We have also discussed the proposed 10-year strategic review. You will recall that the Minister mentioned this at the Bevan Commission conference last week or the week before. So the Confederation is helping to coordinate chairs and chief executives and the other groups like the planners to try and produce a starter for 10 in terms of what needs to happen with the development and delivery of care over the next 10 years. We've also discussed the anti-racist plan, which comes in now. And we looked at the proposals relating to the outcome of a national review into commissioning organisations on a national basis, you know, WISC and EASC and the NCCU, which we have never actually held to account. The arrangements are going to be discussed further by chairs because it has a few things in the recommendations that come from the minister that we think need further discussion, particularly those relating to regional planning and delivery of care, where actually we've made good progress between the 3 health boards in the southeast of Wales, and therefore we wish to continue with our arrangements rather than have a third party undertaking that for us. I also attended the Chepstow Town Council meeting at which some county councillors attended, and that was to inform the Town Council about the developments that had taken place at Chepstow Hospital, because when I met them about 2 months before, it was clear that they had not been kept up to date about what was actually being achieved as using Chepstow as a base. And I think they were very impressed with the development of real community orientated care, working with the general practitioners and with the specialty frailty services. They were very impressed at what was being achieved. Certainly the general practitioners are most enthusiastic about it, and as are the patients themselves, because it's a much more accessible service, and the other proposals that are being effected in that area. So that was a positive meeting. I've also chaired 2 regional partnership board meetings, and I'll come back to that later. We've had a meeting with the Minister as chairs. She expressed her concern about waiting lists, cancer waiting times, urgent care and delayed discharges of care. As you all know, we have approximately 220 people awaiting discharge at the moment. She is very, very keen to see our proposals on how secondary care is shifted to the community. And obviously she's extremely concerned about the financial pressures and the consequences. Subsequently, she has made an announcement about the revision of the strategy for the health service and the way in which it's run in the next 10 years. And she's also announced the establishment of a ministerial advisory group into governance and the accountability of health organisations. We await the terms of reference. She's very, very keen that this advisory group has a number of people on it, and I understand it's not going to be very big, but a number of people on it who are from outside the health service to get a broad perspective on how this might be reorganised or refocused. And I know that the health boards will be putting forward their proposals and their views to the ministerial advisory group when it gets up and running. It's supposed to report back to the minister on the 31st of March next year, so they haven't got a lot of time to do this. I also had my assessment, performance assessment from the minister. I have no idea how that's gone, but I'm still here. And one of the nice things that I had to do, apart from going to see the was that I attended the 75th anniversary of the NHS at the Senedd, which was a very good opportunity to catch up with people one hadn't seen for some time, and to have reacquaintance with many that I haven't seen for a very long time. And the First Minister in his speech was really quite inspiring. He was extremely good. And I do hope we get a copy of his speech, which we can circulate. It was really, really good. He was excellent. The Minister had to go to the Westminster version of the 75th anniversary of the NHS. So that is basically a canter through the additional things I've been doing in the last 2 months. Are there any questions? No? Okay, thank you. Nicola, your report.
Yeah, thanks, Chair. So just a few highlights or key issues to mention. So I can't believe the first quarter of the new year is already kind of over. It's been a really busy time, continues to be a busy time, particularly finalising the annual report, annual accounts, which I know we're coming on to later in the agenda. But really focused our efforts in the first quarter in the plan, already seeing some signs of improvement. I know I've talked previously around the work around safety flow and trying to improve flow across the system, particularly the ambulance rates, which we know is a key priority, and we continue to see an improving trend. Still lots of work to do, but we're definitely seeing the benefits of all the hard work of the teams across the system. Planned care, as the Chair mentioned, in terms of key priority for the Minister and for us, and we continue to work on those long waiting lists to hit some of our key milestones this year, and we'll pick some of that up in the performance report later. And cancer, again, seeing some improvements in the first quarter in terms of how we're doing around cancer. So recognising those kind of very high on the ministerial priorities, that we are seeing some early signs with much to do. But I think, you know, I can't not mention the challenging financial context with which we're trying to deliver that. And we pick that up later as well through the finance report. But a hugely challenging year ahead for us, I think, in terms of the financial challenge, where we're actually trying to take costs out of the system rather than just trying to avoid new costs coming in. And I think we really are looking at how we've got a number of sessions with our senior leaders in terms of our choices and options and how we enhance accountability across the organisation. Really focus our efforts in the next quarter on this and really take a much firmer position about things that we can't invest in. So, you know, real top priority for us as an executive team and a board and an organisation, and how our communication to the organisation on this is something that we need to get right as well. It's also a key focus of Welsh Government and Chief Executives collectively. We've had a few sessions together in terms of what work can we do on a national level to try and help address the challenge we're all facing, because it's not unique to this health board. But in the centre of all that, quality and safety remains at the heart of what we need to do. We all know good quality usually costs less, and if we get things right, we become more efficient. So trying to keep that at the centre of what we're doing. And I think the reinstating the patient safety visit has been really good. I think others colleagues have welcomed that. I know the visits I've done in particular, and the work that the teams have done, particularly around reducing agency usage across the hospital, particularly around nursing. Healthcare support worker agency is down significantly from this time last year, off contract agency, and the messages I was getting from the ward staff was that, you know, that is better, and we are using less agency, and the staffing does seem to be better on the ward, and we can pick some of that through the people plan later on. So I think that's really to acknowledge the progress on that. And another key priority is around communication, continuing our communication with patients, families and the public, our complaint handling. Jen and I are working hard together in terms of how we strengthen our patient liaison services and help families and patients during their experience where they need help rather than wait till later in the process. So a real key focus for us. Still got lots of work to do in that area, I think, but a top priority still. And then finally, as the Chair mentioned, NHS 75 was a big event, lots of work done across the health board. It's a good opportunity, lots of feedback from the teams, and it does lift the spirits of the staff. You know, there was fun days, there was, I think, up in Yab, they'd all put on old uniforms. There was afternoon teas, the schools got involved in terms of making fun, they had choirs in. And I attended the Senedd event with the Chair, which I share views on the First Minister. Some really good sound bites in there I think we should hold on to. But we couldn't do it without visiting Tredegar, so you might have seen my windswept Facebook Live up in Tredegar, but it was a great opportunity to go and visit the new Tredegar Centre that's being built up there as well. So so a really positive event for the Health Board, and the communications team worked exceptionally hard, and I know we got a communication and engagement report later, but really did try to capture that whole event. And then finally, I attended the RCN Awards, the Royal College of Nursing Awards for Wales. We had two exceptional members of our employees of our organisation. So Natalie Janus, she was a finalist in the Innovation in Primary Care and became the runner-up. And Amanda Went, who she won the Older People Award for the work she's been doing on dementia. So it was really great to get some of the staff recognised at that really prestigious event. So that was all I was going to pick up. I could talk for a long time on all the things going on, but I know we'll pick up some of these issues as we go through the agenda. Thanks, Chair. Thank you.
Any questions to Nicola? No? Okay. Can we move on to 2.1, please? To receive Audit Wales's Audit of Accounts Report 22-23. Tracy.
Thank you, Chair, and thank you for inviting me to the board. So we've now received all outstanding information, you'll be pleased to hear, and so we've now completed the statutory audit of the Health Board's annual report and financial statements for 22-23. Once we've received the signed letter of representation from yourselves, we intend to issue an unqualified opinion on the financial statements, but the Auditor General will be qualifying his regularity opinion due to the Health Board not achieving its first financial duty, which is to break even over a 3-year period. The Auditor General's opinions can be found in Appendix 4. A more detailed explanation regarding the qualified regularity opinion can be found in our narrative report to the Senedd, which is in Appendix 5. Before the Auditor General is able to sign his opinion and report on the 25th of July, we will require confirmation from the accountable officer to confirm that they would still sign the accounts on the day that the Auditor General is due to sign. And I will send an email out today after this meeting requesting that confirmation. Turning to page 37 of the board book, just to highlight, there are no uncorrected misstatements. Apologies, it's page 38 of the board book. There are no uncorrected misstatements, and we have detailed in Appendix 6 those misstatements which have been corrected, which we feel should be brought to the attention of those charged with governance. We are required to bring to our attention those matters arising during the audit that we consider significant, and we've detailed these in Appendix 2, which is on page 39. I wasn't going to go through anything in detail, Chair. I'm happy to take any questions, but before I do, can I just mention that in paragraph 21, the end of that sentence should read autumn 2023. Apologies for the typo. And also the date within the audit opinion and the report to the Senedd should now be dated the 25th of July. Unfortunately, we did have to have a change of the planned Auditor General signing date. This also means that the date in note 29 to the accounts also requires amending from the 24th to the 25th. But other than that, happy to take any questions. Thank you, Chair.
Thank you, Tracy. Are there any questions to Audit Wales? No. Okay, thank you. Can I call on the Chair of Audit for his recommendation relating to the annual report and accounts?
Yeah, we took it through audit committee yesterday, obviously, and yeah, we recommend it to the board for signing as well as the rep letter, obviously.
Any additional comments?
No, we've got a couple of small additions that need to go into the report. I don't know if you've got them there, Arnie, of what we need to just change in there.
Yeah, so a summary notice has been circulated to the board that just picks up 2 administrative changes to the versions that have been provided to the board today. There are no further changes to those.
Okay. So thank you. So can we approve and sign the annual report and accounts, please? Yeah.
Yes.
Thank you. Okay. Can we move then? Well, I think Tracy has As agreed, or do
Yeah,
we have
so-
to do that separately?
No, so just to confirm, in the approval that you've provided, it will be to approve the signing and authorisation of the annual report and accounts and the signing of the letter of representation, the
That's
submission
fine.
to the Auditor General.
Okay, thank you.
Rob just wanted to.
Rob?
Yeah, thanks. I'm not unsure if we're going to go through each section, but I think there's probably not need to. Can I just give thanks from my perspective to my team and to the audit team as well. We've had a different process this year that has worked very well, better than I think everyone was expecting, and just want to thank everybody for their input to that to get this positive conclusion. Thanks.
Thank you very much, Rob. Thanks to you and your team for all that hard work. Okay, on we go. 3.1, the report from Fleiss. Gemma?
Morning, Chair. Thank you.
Morning.
Thank you for allowing me to present the first Fleiss report to you this morning. Without going into great detail of the items, I just want to offer assurance that for continuity, items of work that was still open and active under CHCs has been handed over to Fleiss. So active service change, concerns handling, and surveys and report writing. So everything in CHC legacy was handed over. But just some items of note from our report. For the first time, I've entered in some advocacy service data for you so that you can see what types of concerns and inquiries are being raised with our service. So I hope you find that information helpful. We get about a 30% return rate on people requesting advocacy service packs and then them actually moving forward to a formal complaint. So we monitor that quite closely. But as you can see, we're getting quite usual feedback from people about access to mental health services, waits for ambulances in the community. But also we've had some really good feedback about the adult weight management service and some commendations for the NHS staff who've been working really hard through really challenging times. So it's really good for us to be receiving compliments as well as concerns as well. And we do pass those compliments on so that teams receive them directly too. We've continued in representations that we've been needing to make. One of the items that is a priority for us at the moment is the Crickhowell Group practice matter that is being handled by Powys Teaching Health Board, which affects a large proportion of our Abergavenny population. So Gwent, Fleiss and Powys Fleiss are working collaboratively to work with Powys to come to some sort of resolution in terms of any consultation that they need to do with our community. So I've been keeping the exec team involved and copied into representations that we've made on that in that regard. But you can see from our report that the usual sort of activities that you would have expected from CHCs has continued. We're running surveys for carers, for menopause services. We're also getting out there and actively engaging with our population at community events as well. And I'd just like to offer thanks to the Health Board for its continuity in supporting our volunteers to conduct their visits to wards and departments. So as you can see on page 9, we've done 4 visits to Neville Hall over 4 wards, apologies. Nothing untoward to report here. Our reports will be with you shortly, so I hope you find those helpful. And I'm happy to take questions, Chair.
Thank you very much, Jem. Pippa?
Thank you, Gemma. As always, really useful and interesting. I was interested in the advocacy service and the public feedback. And now that you're a national body, not that you weren't a national body before, but a bit more cohesively national, I think, is there the opportunity for us to be able to compare Gwent with other regions within Wales and other communities so that we can learn from other people in this space?
Absolutely. Yes, so one of the priorities for the new organisation is that we're going to centralise our client record management systems. So we're developing a CRM at the moment. That won't just capture advocacy, it will capture our visits, our engagement activities, formal representations that we've made across Wales. So there will be consistent data handling for Fleiss across Wales in the future. But before we get to the CRM launch point, we're starting to centralise all of our information through whatever spreadsheets we hold now in our Datex data information system that we have now. So yes, there will be comparable data and information across Wales shortly.
Brilliant, thank you.
Thank you. Peter.
Thank you, Chair. Thank you, Gemma, for the report. Just a question about the planned survey on transition for children moving into adult services. Really welcome this. Thank you, Gemma. Just a question, really. Will it include children who are using mental health services as well as other services?
It will, yes. Thanks, Peter. So we're working with the Children and Families Board of the Regional Partnership Boards team to do this joint piece of work. It will be across all children's services for chronic conditions, mental health. We're asking a very broad question of children and young people about what it's like to either transition from CAMHS to adults or from other chronic conditions into adult services as well.
Thank you.
Thank you. Are there any further questions to
Gemma?
No, well, thank you very much, Gemma, and thanks to you and your volunteers for the excellent work that you undertake. Your reports are always extremely useful and helpful to us, and we really value them. So thank you.
Thank you.
Thank you. 3.2, the patient story on children's rights and participation. Jenny.
So we've got a video for you to show you from the forum, and I should preface this by saying that it is 10 minutes long, but it is very much the story of families who are perhaps struggling in some of our services. It is their description of their children and their description of their struggles. So some of the terminology may seem strange, but it is very much their description and their story. So I'd commend you to listening to it because it's quite powerful about their experiences.
The pathways are really, really tangled. I liken it to walking through a dark woods and being left alone with no torch and no map. And you're stuck, just left on your own in darkness. Once you've kind of stepped into those woods, you have no idea where you're heading.
I'm Rebecca Stanton. I'm the Regional Children and Families Transformation Lead for Aneurin Bevan. And part of my role is to support services thinking about how they might do things a little bit differently. I have a very keen passion in co-production and engagement and participation with people. And this group came about because within neurodevelopmental services for children, we had a few issues in terms of waiting lists and people not really satisfied with the service that we were delivering. We decided to reach out to Kerry Reid, who is our Parents of Voices director, and ask her to support us setting up a co-production parent group.
So the aim became to bridge the gap and to improve support for families across Wales by providing them a seat at the table. We've co-produced the NEST framework in Wales. We sit on the Children's Commissioner for Wales and Ambitions for Wales, and just supporting parents and other groups really across Wales to give them a platform.
I'm Lisa and I'm a mum of 2. I am dyslexic. That's something that I'm very passionate about, especially spreading awareness for people with dyslexia, making sure people are supported correctly in work. The reason I joined this group was because I wanted to make a difference, just like I'm doing in work. And I've done this because my son, who is neurodivergent, will hopefully one day go on to have his own children, and they are likely to be neurodivergent because it runs in the family, obviously. We've had lots and lots of battles with various different people along the way. So this group has really kind of enabled us to bring together many voices to share our experiences and also come up with the ideas to kind of fix where things have gone wrong. We've fallen through many pitfalls ourselves as parents, and what we wanted to make sure was that other parents don't fall in the same pitfalls, because, you know, it's a bit traumatic and it kind of hurts actually, especially when you're talking about your own child. Things get quite passionate.
My name's Natalie. I'm a mum of 2 neurodivergent children. Before Eva was diagnosed with ADHD, a couple of years leading up to that, was a really difficult time for me as a parent. I felt really lost. I tried to reach out to some different places for help. I tried to go to the GP and local charities. Eventually, she was diagnosed in 2018 with ADHD and privately, because the waiting list to see somebody via the NHS route was really, really long at the time. And we didn't really get a lot of support either from the school. A lot of parents come to us from the support group and they feel like they don't know where they are on the waiting list, or they don't know what the next step of the process is. Or after there's been a diagnosis, they're not sure, what happens next or where the support is.
I'm Jolene. I'm a mother of 3 amazing, feisty, strong-minded, neurodivergent children. All 3 of my children, especially my older 2, were really struggling with school. I always knew there was something, with them, but I didn't know much about neurodivergence, so I wasn't sure exactly what it was. The kids were struggling to attend school. School weren't supporting them meeting their needs. They were going downhill. I got to the point where I had to leave my job of 20 years, which massively affected me in every way. Nobody seemed to be listening, and I got to a really, really dark, low place in my life. Myself, I'm also ADHD and autistic. Learning about my neurodivergence has completely changed my life. And so it wasn't long after that I found Parent Voices. I remember the first couple of meetings, I was a bit intimidated. I never thought anybody would want to hear what I've got to say or listen to my story, or my ideas.
I have 2 sons. They are 13 and 16. Even though both my sons have a diagnosis of attention deficit hyperactivity disorder, they present in extremely different ways. My older son, nobody realised the difficulties that he was facing when he was going through primary school. And with the onset of the teenage brain and adolescence and puberty kicking in, he was then overwhelmed with anxiety and couldn't cope and shut down completely. It's extremely isolating for the child. They don't get invited to birthday parties, for example, because nobody wanted him there because he was the naughty boy, and so he just didn't get the invites. People stop making eye contact with you when you go to pick up from school in the playground, and you are judged very much in your parenting skills. If there'd been somebody there to hold my hand 10 years ago when my 13-year-old was 3, and I was first thinking, he's not like other 3-year-olds, he's not presenting in the same way. And it still took us a long time, even for him being diagnosed at 7. Never mind my older son at nearly 16.
The radio silence you get is actually deafening, because you just have to just sit and wait and hope that you are on a list and that your name will be called at some point in time. One day you do finally get that letter to say that assessment's going to happen. I know we've done so amazing things. I know we've put in place brilliant leaflets to signpost parents, and even kind of put in people's pictures of who the specialists are that our children are going to be seeing, which is just brilliant, because that's not something we had in the process.
You need the voice of a parent, especially neurodivergent parents too, because in a service for neurodivergent children, there's quite a good possibility the parents are too. The confidence that's given me has led me to getting involved with so many things. I'm part of a programme called Equal Power, Equal Voice now, which is through the Welsh Government as well. And that is to get more neurodivergent people into public life. Being confident enough to put different ideas that pop into my head out there into the world. When your child is really struggling and you're on endless waiting lists to try and get seen, you're pressured to keep getting your child into school, and then you're pressured to find evidence, trying to get your doctor to believe you so they'll put a referral in. But in that meantime, you're just waiting and you're left isolated, trying to support your children who are desperately in need, but also you're falling apart yourself.
I joined the co-production team a year ago in order to try to help others to navigate the system, which is like a minefield. The peer support that is offered to everybody is absolutely invaluable. Having a diagnosis really helps once you get to that stage in the system. The main reason for having a diagnosis is that it opens doors, particularly in the education system. And in the case of ADHD, medication worth trying if you feel happy about it. My 13-year-old was medicated for ADHD just over 2 years ago, and it has transformed his life.
I love being part of the co-production committee group that we're in. It gives us a chance to feed back the voices of the parents and carers that we represent in our group. It gives us a chance to put ideas forward on things that we would like to see, to share some of our struggles and explain our struggles to somebody. It means that we're listened to, and that when services are developed, it's done in partnership, it's done together. The reason that I do this and the reason that I want to be involved in co-production in this group is to help other parents who might have gone through a really difficult time like I did.
I can't stress enough the impact of being stuck between a school and the healthcare people, I would say. It's horrible. When you get refused a referral for your desperately needy child, when your child starts to fall apart, there's no safety net. They're just left to fall.
I think a lot of the time ADHD can have a kind of stereotypical view and people don't really understand the complex nature of ADHD. And by letting other people know that I've got ADHD and I still have a good job and I can still parent well and I can still be successful and I can still do all the things that I want to do in life, by embracing the fact that I am different. And I think it helps young people and children to hear that story and know that, yes, I've been diagnosed with ADHD or I've been diagnosed with autism, but it doesn't necessarily mean that that's a negative thing and that there are positives from it as well.
I've seen the parents developing their confidence and their ability to come up with some amazing ideas. And what I'd really like to see long term is this happening with every service. The outcome for me is constantly having that feedback loop.
I just hope we see this in all areas of Wales, so that everybody who has a child with challenges has a seat at the table.
Going forward, I think what I'd love to see is this dark wood turned into a beautiful meadow with lots of information, lots of things to look at along the pathway, so we don't all feel lost and alone.
Thank you. Are there any comments, questions? It's very powerful.
Yes, I was going to add, it's a very powerful example of an issue, which I think is becoming more of an issue. Part of it, I think, maybe COVID related, and the fact that there's a lot of sort of time frames there. But so the influence of COVID, I think, has been an issue. There's been a lack of, in my view, a lack of awareness and understanding of the issue, which that evidence quite clearly. And Becky Stanton, by the way, is incredibly positive and enthusiastic in nature, so she's a great ambassador for that. But there is an issue, I think a recognised issue nationally, about the assessment process. The assessment, I think the waiting list, according to one of the newspapers the other day, was a 7-year waiting list, potentially, for the assessments. Some individuals are going for private assessments, but then there was an interesting panorama programme on the other week, which then questioned the whole sort of issue of these assessments by phone or by a virtual discussion with an outcome, which was actually medication. So I think there's this is, I think there's a massive, I think, perfect storm if we're not careful of young people so needing perhaps help and assessment. The question is, where are we with this health board with regard to potential numbers, the assessment process, the time frame, the support, and also where are we with perhaps the third sector? Where are we with schools? In other words, how are we looking at this as a holistic issue, as opposed to, well, that's, as a former high school teacher, you know, if you get somebody in your year group who it was different, then if they go through if they are if it's a behaviour issue, you try to unpick, well, why is that? And of course, it's whether or not there's that support available to schools to say, well, you have got somebody in your year group who needs help and support. And actually, in one particular case that I can remember, the child was very sort of badly behaved, but it was all to do with looking at the blackboard, and actually the result was wearing a different colour lens, and he could see the words rather than dyslexia going all over it. So I think sometimes it's just trying to pin down some of the issues. So I just wonder where we are with all that in terms of the assessment process, the time frames, the support, because that highlighted an issue, and I think it's just not. I think there's going to be an exponential increase in this, and of course there is a link then with disability, because I think it's a recognised disability in terms of disability living allowances and the disability processes and accessing the support. So I just wonder where we are with all that. I don't know whether that's for you to answer, Jenny.
I think just before Leanne or Nick want to come in, I think there's something about, this is probably a group where of the hidden weights that Nicola often talks about in terms of us understanding the need. I think one of the reason I wanted to bring this was because Becky was really keen to work with families to tell their story. Mm. I think in knowing their story, we can do work with those families to do something about the pathways. And I think their description of having going through a dark wood and wanting to get to the meadow where they've got a sea of information and understanding, I think that's the beauty of the co-production group that now exists. And I think that the support we can provide in that environment is our opportunity really to do something very different. The weights are probably going to be there, but it's how we support those families in the meantime, and working in a collaborative way with education, and with social care. It's not a one agency approach, is it? You heard them saying, the gaps between education and health. I think it's really important, isn't it, that we try to bridge that.
Nick, do you want to add? Yeah, just to build on that. So I think to separate them into two. So there's the bit that when it is our part of the pathway to health, have we got the right mechanisms, and I'll bring Leanne in and some of the work we're doing in terms of improving that. I think we've done some really good work around in-reach in schools. Some of the reward within this space, the schools where we are trying to in-reach into schools at primary school level as well, rather than waiting too late in the process. So there's some good work going on around that. We've got more work to do. I think we have made improvements, but we know we've still got patients waiting beyond the 6 month timeline for ND in particular, and there is an improvement plan on that which we can pick up, but I am concerned with some of those weights that are in that area. There's some particularly long tails on the end of our waiting list that we're trying to focus on. But then I think that wider piece around the partnership agenda and how are we working around the multi-agency, because when you listen to a lot of that, it is about trying to navigate your way through the different partners, from the schools to social care to health, and how we make that easier and wrap around that support for people. So I think that's a wider regional piece, as Jen referenced. So I think it's thinking about what was in our direct control that we need to make sure it is good and as good as it can be, and then that partnership piece. But Alana, I don't know if you want to add anything about our particular.
I think it's a great question, Paul, and very timely, because it was one of the areas that we've got down for a sort of board development session sort of in the autumn, not just from children's sort of services, but adults as well. So just for some information and context, you're absolutely right. The demand post-COVID in particular has rocketed. Adult demand has doubled. Right. So there is a requirement to think very differently, I think, about how we provide these services. So we'll go into some of the detail of that via the board briefing, but happy to link in with you sort of outside of the meeting to come back and share, I guess, some of the plans. But Nicola's already alluded to this. This is not just, I think, sort of our responsibility, how we come together sort of with our partners, I think, to resolve some of this, I think will be absolutely key, and help families and our population to signpost them for self-help as well, where that's appropriate, because certainly some of the conversation I've had with the teams is sort of the people that were coping pre-COVID are not post-COVID. Yes. So actually I think sort of the service models that we have need to sort of fundamentally change. And it's interesting to hear the parents talk about their needs as well, and I guess reflecting that adult doubling of demand. So there's a lot of scrutiny on it. There's a requirement for us to be clear on the demand capacity that we've got, and then we're clear on the weights. But back to Nicola's point, I think we will be shocked by the length of weight that we're getting because of the doubling of demand. That's not to say that we accept it, but we have to work, I think they said, sort of with our partners, I think, to come up with solutions so that people do get the help that they need.
Martin, then Tracy and Hannah.
I mean, I think there's two things for me, really. I think I was really concerned about the fact that at 3, it was picked up in the video that the child didn't fit in. It just reminds me of my own personal experience, my children's experience. Some are boys, they often struggle when they join school because you're trying to contain them in a very rigid environment, partly because you've got 30 kids, you can't have 1 or 2 going off. But then you sort of feel that in some ways the education system, our head wasn't particularly good at dealing with our son. And it's partly because they couldn't really understand difference. And I sort of think sometimes you have really good examples. We actually moved him and it was, there's another state school that worked really well. But it is that working with education to actually say, it's okay sometimes to not expect every child to behave in a certain pattern, particularly when they're young. I also sort of feel that co-production is really, really important because you cannot provide all the services you need. And sometimes with co-production, I'm just thinking again as a parent, if I would have known of a group of people who might have been struggling, but weren't necessarily, I think my son eventually got diagnosed when he went to Hereford Sixth Form College. So he was never diagnosed while he was in Aneurin Bevan, then he's fine, he went to university, I think. But I think the co-production thing is assurance amongst people, but also if it's peer, it's not constrained by office hours, it's not constrained by professional, which is quite understandable that you've got to, you can only manage so many people. And I think that's where the third sector can really maybe support, I would have thought, in terms of that. And I think that is saying that throughout, even with cancer, people with cancer right across, that co-production is really, really helpful. And peer support, I think, is something that is relatively cost effective and really powerful. That'd be mine.
Thank you, Martin. That was really helpful. Tracy?
Chair, I think your points are really well made, Paul. And I say that personally and professionally. My son's got autism, and I remember the challenges he had at primary school, being left out of birthdays and not fitting in and those kind of things, which are really hard to rationalise for a child that is aware enough that he is being left out. And I think some of those challenges play through. Had a really interesting conversation with the directors of social care on Friday, and it was just a general conversation in terms of the contribution of public health in that space, and talking about these things and the best start in life and how we refocus on that as an agenda, and neurodiversity is part of that in terms of diagnoses. And one of the things that we don't do well in Wales is understanding school readiness and the data around school readiness. So if you look across to England's data, about 1/3 of children start school before they're ready. And that is all sorts of things that are probative about that. It could be about toileting, it could be about language, vocabulary, it could be about undiagnosed neurodiversity, which means that they're not ready to learn. So I think we need to be more aware of that, both in terms of our current, in terms of number and capacity of what we need around that, but also the projections. There's emerging research in the space around neurodiversity. It's only recently it's been accepted that there is a familial trait in terms of hereditary around neurodiversity, which is new knowledge. But there's also a link in terms of biome health, so gut health, in terms of how that can trigger neurodiversity and exaggerate the symptoms of it. So a load of research is going in that. So I think there's a huge field that we can start to learn on in terms of understanding this. And I think going outside of, I think the co-production work with the families affected by this is important, but there's also an awareness piece to do with the wider population in terms of how we include children that are different. And as parents of children in classrooms where there is a different child, make sure that child's included Now that may mean a direct conversation with that child's parents to understand how they can participate in a birthday party, which may not just be muck in and enjoy the noise and the mess. But I think it's really important we find a way to include these children for their future health and well-being. So that's the sort of conversation that's been started, but it's a huge piece of work. But I think it's one that we avoid at our peril almost, in terms of making a real impact on children and how they grow into healthy adults. But it's a start, but I think we've got a lot to learn in this space.
Thank you. Anna and then Pippa.
Thanks, Chair. Yeah, just to build on some of Tracy's points there, I was going to refer colleagues to page 4 of the Q1 outcomes report we get to later, which has some of the some detail in terms of where we are on delivery against the 80% of children being assessed within the 26 weeks. And we are, just a heads up, we are not performing anywhere near that standard at the moment. But I think just that standard alone sort of belies that, well, so what's the longest wait then? And we should be, so something for me about how we think about what are the important metrics to be tracking here. We know we have to report on that, but what are the actual numbers and what's the sort of the shape of that waiting list? And it does also refer to the work in terms of the children's space, recognising that this is an all age issue. It's been split, that the improvement work's been split in terms of 5s and unders and the over 5. So it does refer to some of the improvement work that's in train, but we have a lot to do. We are under 40% of delivery against that, and we aren't forecast to deliver that in spite of some of the interventions. So I think the session that Leanne referred to will be really, really important for us to understand and back the opportunity. I guess the other bit I was just thinking of, as Tracy referred to, the sort of the general awareness out there. We do a lot, don't we, around dementia-friendly environments and making sure that it, from families through to sort of communities and different sort of places, have awareness of people with dementia. I just wonder if this sort of model could be the same with people who are neurodivergent, to make sure that we become a bit more kind and compassionate as communities towards this difference, which we should celebrate. We've all got stories people close to us with neurodiversity.
Thank you. That's a really helpful suggestion, Hannah. Pippa?
Thank you. And actually, picking up a little bit on what Paul was saying and what you've just said as well, because we've got the waiting lists, and we know that what we're talking about here is probably an unknown number of children as well, and adults and people who are seeking a diagnosis. And for many people, once they get that diagnosis, all it does is explain something. They're not going to take medication for it. They may not get any treatment for it in the medical sense. But understanding why your behaviour is a certain way, as to your point, Paul, about people getting picked up in school because their behaviour is not within what people would see as normally acceptable. And so that it's at that point that people are looking for solutions, looking for answers to know how to manage living with a condition. And I think although health can't do everything plainly, there is something for those people who are already seeking a diagnosis in terms of understanding how to do that day-to-day living that we're probably not doing very well. For people to be aware that there is no magic bullet in most cases, that there isn't going to be a pill that you take every day that's going to fix things. So therefore, how do we shape learning for not just the parents and the children, but also the schools, particularly schools, to say these are the kind of approaches that you will need to take after your diagnosis, so you could take them now, if that makes sense. So I think there's something around how do we think about that awareness raising? How do we think about what are the resources that people need, and then what can we put into that, either through peer groups or working with education, in order to make that happen. So people, even while they're waiting for a diagnosis, are already on the path to this is how we're going to live our lives, so that we turn into successful adults, I guess.
Thank you.
And can I just make 2 final points? I think
The two things I'd say is we shouldn't lose the experience in the data and the experience of people who are trying to find solutions for their children and to access services. And I think we need to make sure that we don't lose their voices in this. And the other thing I'd say is that it's really, really important in designing any solutions. We use the co-production group because that's what it's there for. It's not only there to support each other as they're going through this process, it's to listen and learn about what would make a difference to them and their child. And I think that's going to be really important, and why that group is so different, so important that we support.
Just very briefly, I don't know, we have responsibility for the prison estate as well, for health-wise, don't we? And I was talking to someone yesterday from the MOJ about neurodiversity in the prison, and I do sort of think that we need to be thinking how we're supporting that population as well, because as you said, then they've lost their parent, which they're children of, and they're likely to have neurodivergent issues themselves. So I sort of feel in all this debate, we need to make sure that the prison estate is also sort of seen as quite important.
Absolutely.
Final word? Yeah, I just wanted to pick up on the point of peer support in it, and it goes back to the last meeting's patient story where we talked about the alcohol care team. And I attended the alcohol support group that our clinical teams had put together on Friday, which was it was so emotional and inspirational in terms of how that group is supporting each other. They all believed that they would be back in hospital, not there, if it wasn't for the support they've gained from each other in that support group. And it's the same. It's the same theme here about what peer support can offer, I just wondered about how we take a more broader, approach to peer support across all our services in terms of where they absolutely would add value. We talk about the financial challenges. This stuff doesn't cost money. This is about connecting people and helping them with their own well-being. They phone each other in the evenings when they hit a bit of and to be honest, even in the alcohol, when underneath all of that was a bereavement issue, there was family breakups, there was trauma early in life, and actually we should have potentially been supporting them at the earlier stage than when they got to the alcohol. So I just think it's something I'd like us to think about in terms of taking a more broader approach to peer support, linking in with the work we're trying to do across our communities in our prevention space, and that I just think is so powerful, and I think we're just not doing enough of it. Yeah. So I just wanted to share, because it linked to last month's story as well, but it's something I'll pick up with it and to think about where we take that.
I'll pick it up with Tanya, because obviously Tanya runs a number of, we've got a very live dementia peer support group that's doing great work. We're looking at doing that with cancer. We're looking at doing it with a number of different groups. With end of life, bereavement. So I think I'll talk to Tanya about the work within her team.
Good. Well, that was really, really helpful, and lots of good suggestions there from it. And we look forward to the session later on in this year, and possibly by that time, some of the initiatives that we've been discussing have been taken forward. In the partnership arena, of course, we must not forget that additional resources have been provided for neurodivergence to the RPB, and we anticipate having a report on the utilisation against needs at the September meeting of the RPB. So to progress some of the good work and the improvement in care and outcome for individuals. So we'll come back to this, vitally important. Thank you. 4.1, primary care provision. Leanne.
Good morning. So 2 papers under primary care provision. I'll deal with the first paper. We've had 2 contracts that were handed back to us. Sort of notification was given in February for the Lawns and in March for Churchwood. There was a vacant practice panel in May and June, respectively. And I'm pleased to be able to report that the vacant practice panel have recommended and has been ratified sort of from execs in June that contract should be awarded for the Lawns to Dr. James and Partners, and for Churchwood to Dr. Ahmed and Allinson. with the plan that the contracts will commence in September and October respectively. So just requesting board support for the award of those contracts to allow us to continue, I guess, with the holy grail of primary care sort of sustainability. But I think positive news that we've had multiple business cases for both of those practices and that we've been able to award successfully. Just out of interest, because I'm nosy, I sat in on the vacant practice panel for Churchwood, just in terms of some of, I guess, sort of my understanding, interest and curiosity, and there are some really good contenders out there now, I think, from a sustainability, which I think gives me hope that we can continue maybe sort of to approach or review, I guess, some of our managed practices going forward as well. So just request from the board to support the award of those contracts.
Thank you. Are there any comments? Ewan?
I've just got the one. It's not with these particular practices. Is there an overall plan, a 10-year, 20-year plan of what we think we need in terms of primary care, you know, with building developments and everything else going up, of where we think we need various banking terms of where we need branches or where we think we need surgeries and that kind of thing?
I think there's a broader piece around place-based care, and it starts off with a population needs sort of assessment. Do I think that there's lots of work ongoing in sort of the strategic space at a Welsh Government level? Nicola is Chief Executive Lead for that on an All Wales level. I don't think it actually addresses the problem for us. That's a personal opinion. And I know that some of the models that we're having, some of the applicants for the business cases offer a different proposition. They're slightly different, I think, from maybe a Welsh Government sort of expectation. So I do think that we need to review that. We've taken some steps forward in terms of the Primary Care Academy, in terms of the training provision as well, from a sustainability piece. But I think that there's more work for us to do here. There is a strategy. Do I think it will deliver what's required? No. Do I think that we need to think more broadly about that? Yes, for sure. Do I think there's the appetite of that in even just sort of the short 3 months that I've been in sort of this role? For sure. There definitely is. But and I think, back to your point, you know, what estate we need, we've got to determine the service model first. We've put a pause on a couple of the health and wellbeing centres as well, because I don't think that we've really maximised that opportunity with our local authority partners, third sector, and I think we've got an opportunity to influence that for sure.
So the feeling I've got, I mean, obviously a lot of this is reactive because people come to us and throw the keys back kind of thing, and a lot of it. So when would we expect to see, you know, if we're going to incorporate into a bigger estate strategy, or just a review of all of this and what we need going forward? When would we be expecting to see something?
I think
as a board now.
Yeah, no.
When should we look to get something back?
I think that we should be able to bring something back to you. I'm going to suggest sort of autumn time, looking at sort of Nicola in particular and Hannah around sort of our strategy piece on this. There is a broader refresh in terms of our strategy anyway that I think is required, but I think place-based care is at the heart of that for sure.
Yes, absolutely.
I mean, just following on from what Ewan said, I mean, I don't know whether this is correct or not, but historically the model was GPs are businesses and they would buy a facility and then people would buy into that model, and GPs, when they bought in, would spend a lot of money buying into it. But that model seems to be historic, and GPs prefer now to be sort of associate members rather than having to buy into the product, the business. So it's whether or not the model that we've currently got, there are a number of areas of Gwent where you've still got those historic models where people are partners are thinking of retiring, but actually nobody wants to buy into it because they want to be part-time or the ways of working are different. So I think probably it's a useful question to look at. I mean, how many GP surgeries have you got altogether in Gwent?
70. Yeah.
So maybe at some point to have a conversation as part of whichever the structure is or governance model is, to say, if we're looking at 5 years hence, where do you see your particular service? Because in other parts of the country, what you're seeing is a lot of GP surgeries think actually we want to sell our properties and we want to just rent a place. So you have a central GP location that people buy into in terms of rent the space, but don't have the cost of the building type of costs. And then to have a sort of a slightly different model of working. Certainly that's in parts of England, they're working on that.
You're absolutely right, Paul. The traditional model, I think, of GP partnership has changed enormously, partly because of expectation of GPs when they've trained and come through the system. If you look at some of the English models, because I think we should be looking further afield, and not just in England either. You know, there are big practices. There's a great podcast that I picked up, a federated sort of GP in Peterborough. Really phenomenal. You know, if I come back to place-based care, actually, the provision of services, diagnostics in those areas, locality, particularly linked to some of the health inequalities piece and the prevention piece as well, actually. I think there is a lot for us to aim at, really, I guess, I think, for that plan. But I think we absolutely need to be bringing back what we think our strategy is in the autumn.
Yeah, we'll have a board session on the 18th of September where we can explore this further. But we've got to design a system that is going to suit and meet the needs of the population. And we have got to really use this opportunity to pull out a really modern service for the future so that it's sustainable. Pippa, and then did you also?
Yesterday I was at the primary care workforce plan with HEIW, and they're looking at precisely this problem, that not just limited to GP surgeries. Is if you take all of kind of primary care, it's something like 1,000 employers across Wales between their pharmacies and one thing and another. So there's quite a lot of structure and quite a lot of estate as you put it tied up into this. So I think it's going to be really important for us to understand what their plan is to support new trainees, etc., coming through, and the ways in which people wish to work, and perhaps different roles than we've had in the past, and the way that they all work together. So I think it's going to be really important for us to tie that into the work that we do locally, so that we sit within that structure rather than trying to reinvent some of that. But I think there is progress being made, I think, across Wales.
Yeah. Thank you, Pippa. Hannah, and then final word from Nicola.
Yeah, I think most of my points have been made, but just to build on a couple of them, is we're absolutely right. We need to align a few things and scales around that. So there's our vision for place-based care and the opportunities around that, contextual challenges and the national direction. There's the workforce piece that Pip has just mentioned. There's also in the RPB space the development of a 10-year capital plan, which is where the capital is going to come from through that route. That's just come into the end of an asset mapping exercise. It looks at all of our collective, so from a state perspective, we'll have more clarity on what's available and therefore how our models potentially fit into that. And then there's the risks we've got, so how fragile are the services in particular areas, and we need to get an overview of all of that. So where do we need to, what's the prioritisation of where we need to develop new models, because it's coming in the pipeline of risk in spite of best efforts of workforce and other. So that work coming together autumn time, which aligns with the timescales for the 10-year capital plan.
Wow.
Sorry, yeah, because that's the piece I don't think we see at the moment, is how this new practice coming in, that will not replace how that fits in.
Absolutely.
It's that linkage between the now and the urgent today versus.
And you're absolutely right. You know, you won't be cited on that. I think we have not described that to you as a board as something that certainly sort of I've picked up. There are definitely opportunities there, though. I think just to reassure, and as I've said, sort of we are reviewing the number of managed practices we've got now with a view that we're going to go back out to vacant practice panel, because we're confident that we will get suitable applicants come forward, and actually potential mergers as well. So we're building resilience and sustainability into those practices for the future, which I think is really important. You know, it's the foundation of healthcare delivery, isn't it? It's a solid primary care offer. And it's positive that we've got that, but we absolutely need to describe that, I think, to you.
Yes, and it's urgent. Nicholas?
Yeah, it is urgent because I think what he is describing that he wants, I've been trying to get for the last 6 years when I was in the director of planning job, because I think, as you said, when each practice comes forward with where does that fit into our strategic map, if you like, in terms of what's the population size, that I think we've already, there is a bit of a broad vision about, 10, 15,000. How does that look? What's that equitable offer? Because the big issue, and I was at the primary care conference yesterday, quoting Phil's experiences of that, the vast inequity sometimes between some of our practices. But what is that standard offer? What's the vision? And as each of these things come forward, we can see where it's putting the bits of the puzzle in for that vision. So it is something Leanne and I have spoken to in terms of, let's get what that, as Pippa says, we absolutely need to make sure we keep aligned to the national strategic direction, which I think we are, particularly, given the contractual issues and the workforce. But what does it mean for Aneurin Bevan? What does the future look like? And then as each of these come forward, how much of that is taking us further towards the strategy that we've set out and our vision. So I completely agree with you. We absolutely do need to articulate, I think. And then where our managed practices fit in that, because we've drifted between, it's great to have managed practices, we can influence and do things directly. To our experience, then we struggle to staff it and keep it going and deliver an equitable service. So I think pulling together our vision for primary care in the health board, aligned to the national, is an urgent piece of work that I think we need to pull together.
And there are, a few other. I just happened to be reading an article on Pobble and the funding they've just had from Principality to build however many thousands of new affordable homes somewhere, and that obviously would impact then that strategy straight away if they stick them all in one site somewhere, because that could easily overwhelm something that we had planned.
Just on that point, we need to get more canny and strategic about how we know about those and look for opportunities for the sections that you can access money to actually have a physical facility, notwithstanding.
We all know the issues about massive estates being built with no shops, no medical practice, no schools, etc., etc.
Exactly. Well, we look forward to seeing that, because it's absolutely critical to our ability to meet the needs of the population in a sensible and equitable way. So are we happy to endorse the recommendation?
Yes.
Yes?
Yeah.
I think it's really good, actually, that we had viable competition after what it was like a couple of years ago, where we
Sure.
Okay.
And then the second paper in relation to primary care provision is the Derry branch closure as part of Meddyg for Cymru practice. The paper outlines the case for closure. Just, I guess, wanted to sort of reinforce that set in the context of workforce supply and demand. The list size overall for that practice is just under 13,000, and the number of patients sort of affected for this sort of particular population is 377. Currently, they're spread over 3 sites. It is a training practice. There's been, as you would expect with any sort of branch closure, sort of heavy engagement with CLICE, questionnaires issued, as well as in-person sessions offered. Only 11 patients actually attended in person for that. I think just to give some context to this, for patients that attend, there's 3 patients a week that attend this particular branch. We talk a lot about sustainability and utilising our workforce to maximum effect. Lots of those patients won't be well served by that capacity either. They aren't able to give samples there. They can't access allied health professionals, district nursing, or sort of health visiting from that branch. So it really is, it's not a great offer for our patients, even if they can have an initial consultation there. Often I think follow-up care is required on the other branches as well. And so the recommendation of the panel, and also supported from exec team perspective in June, is that we support the request for branch closure in the interest of sustainability. We have, I think, just for assurance, also shared with Clais and the population some additional offers in relation to sort of potential access to transport, which I think is important given some of the health inequalities there. So request to support the branch closure in the interest of sustainability and scale and maximising the workforce that we do have in primary care for a more holistic, I think, benefit for our patients.
Thank you, Leanne. Are there any questions or are we? Yes.
It's more of a practical question on this one. We have just in the past paper approved the transfer of 5,500 patients from the Lawn to Medwick and Rumley. Yes. And that the paper notes that there's currently they're able to offer something like 1 clinical session per 180 patients. With the closure of with that transfer in, does that number change for this? Because presumably there will be some staff that are transferring from the Lawn to Medwick and Rumley, but then also the closure of this branch, potential loss of 777 patients to other locations. What's the impact on that number of sessions per patient caused by the 2 sets of changes together, not just the one? Because this practice is going to go from I think it's 12,800. We're going to add in 5,500 to that, so it's going to take it up to 17,000 patients in this one practice. What's the overall change caused by the closure of the branch and the addition of those extra patients?
So the panels in both considerations will have factored that in. I can come back and give you the information sort of offline, David, in more sort of in more detail. But the conversation I've had with the team on this is that this is to support the sustainability of delivery of that larger practice. We can't afford to have staff sat in a branch delivering care to 3 patients when it could be delivering to 20 or 30 or 40 a day, which is the norm. Well, that's a day, let alone sort of how many are being seen sort of on a weekly basis. So the panel has to provide that confidence that it's got sustainable staffing to have awarded that contract, and I'm confident and assured that they will have done that in that process.
So do we agree with this closure?
Yeah.
Apparently the lease has run out anyway. Yes. Well, it's a good job we do agree, and there is an alternative. Otherwise, this would have been slightly late, wouldn't it?
There was a conversation with the landlord about extension of the lease outside of sort of the process, I think, to understand the context we were operating in.
Yes. Thank you. Would you mind if I brought forward 5.2, please, with the Trades Union Partnership Annual Report as with us?
Okay. People know I'm not in the process of reinventing the wheel, so the document you have is probably similar to ones you've had before, because it's the same stories, to be honest, about from different topics. But there are 2 points I want to raise. One is about the health visitors, mainly about the pressure they feel under. It's been reported to be within my union, but also in other unions, of how they are feeling, to be perfectly honest. I mean, the general despondency, I'm not going to lie to anybody, across the health board, pay being one of them, I'm not going to hide that from you, but also the way they feel at this moment in time, and actually the pressures that are in the pipeline to come ahead. I think that's going to cause even more pressures and discontent amongst the workforce. But the health visitors in particular, there's a lot of things going on there that has been rumbling on for a number of years now, to be perfectly honest, and where they feel that where there's investigations, for example, or complaints have come in, where they feel that they are being criticised and found guilty before they're actually asked the question. In other words, getting the bigger picture of things, and that is a serious concern. I know people have left, and I don't want to see that happening, to be fair, for this organisation. But that is the end line for some staff, where they feel they just cannot take any more, and that's what's happening. The other thing that's not necessarily in the paper is the fact of mobility for staff. One being, and again, it's currently been brought to my attention again, but it has been rumbling on for a while, where people are, I can understand the rotation of staff from one site to another, or they have development or what have you. But when you have people that are expected to be mobile, but expected also to be in different places for the same start and finish time to provide a service, I think that's encroaching greatly on their private and personal time. But there's no recompense apart from the mileage, and those are the comments well, they get paid for mileage. I think we will acknowledge, I don't know whether you agree, but I think you will acknowledge that the recompense probably doesn't meet the demands on fuel and costs at this moment of time for travel. So there's not only that burden, but there's also the burden of their personal time being eaten into with no thought of any type of recompense, be that monetary or be that time off in lieu. And I think that is a serious concern. As I said, the worst case scenario is a person in Newport, based in Newport, but is expected to be at Chepstow for their same start and finish time, which I think is totally unreasonable. And I think that's a total, that's a disregard. We go on about a caring organisation and thinking about our staff, but I don't think it's really getting back down to the coalface, shall we say, and certain managers within those areas. I'll leave it there. I'll take any questions you want.
Thank you very much, George. Sarah?
Thank you. Thanks, George. And I can see Jenny popped her hand up as well, so I'm sure she's coming in on the health visiting issue. It's interesting that those issues have been ongoing for such a significant amount of time, because I think only in most recent months has been raised to ourselves. I know that there is a report from the OD team which will be shared with service leads next week in terms of some of the issues and concerns raised from staff and some of the listening exercises that the OD team have been carrying out with staff over recent months. I've asked that myself, Jenny and Leanne have a copy of that report so that we can ensure that service leads are taking those actions forward. And I know that there are various issues from caseload management, from responses from management, etc., that will be contained in that report that we can address. And colleagues in the workforce and OD team have regularly been meeting with Bill Morris, the RCN local rep, in terms of continuing that partnership working through that agenda. In terms of the point around mobility, we've talked about this more recently in that we can pick up those specific issues. And I think there won't be a one size fits all, there will be a different response, but being reasonable in terms of our travel time is important where those service needs allow. And I know we had an example of an individual who wanted to work across sites, for example, but that's why I think it's a one size doesn't fit all, and we need to make sure we consider individual responses. I just want to note as well that I think, moving on from the report you presented last year to board, George, we have had several conversations and a trade union partnership informal session on developing partnership working. So there still continues to be work that we need to do. We will do that together. I know yourself and Nicola launched a renewed statement promoting partnership working, and just recently this week at Trade Union Partnership Forum we talked about those local partnership networks as well, and we heard from there some understanding from local managers what support they might like to re-establish or establish local partnership working forums, so we can make sure that that is disseminated through the organisation. So I'm sure we'll work together on that in the year ahead.
Can I come back?
Yes, certainly, George.
Yeah, I totally agree with what you're saying, Sarah. I've said over the years, to be honest, you can be the best nurse, best electrician or whatever in the world. When you have to people manage, that's a different ball game altogether. And unless they get the proper training, they fail at the first step. And that's no fault of themselves. What I will say though, if they have had that respective training and ongoing training, because it's not a one-stop shop, and they are failing, then at least they be looked at as their capability in being able to manage staff. And I think that is a concern sometimes in some areas. I will also say that the Adrian of Wellbeing and yourself and what have you with the investigation, the things at the two places, I can't remember the sites now, to be honest. I think that was a very positive thing, to be perfectly honest. But I think as far as the health visitor is concerned, they feel that managers go gung-ho into a massive investigation of the issue rather than trying to sort it out more at a lower level, shall we say, and get the bigger picture of the things rather than and then being able to deal with it then at a short, rather than it being prolonged as well, because I think that causes more strain, even though they might feel themselves innocent. The longer it goes, the more pressure the individual feels.
And we'll ensure that the outcome of any report and the findings is shared with yourself and Faye Morris, as well as the local RCN.
Well, I'm pleased that we are doing something very active about the comment made by George that there in some places is no or limited engagement with managers, because this was a comment that was made last year, and we really, really do need to improve that situation. Jenny and then Paul.
Thank you, George. I've personally met with Faye and some of the health visitors. I've also met with the health visiting managers, and as ever, when a service is under pressure, there are difficulties and tensions throughout the structure. I know that, and I'm a health visitor myself, that's my clinical background, so I know and understand many of the issues. We have got clearly the work that we've done around the listening exercise, and I'm seeing Chris again next week to try and talk through how we address some of this with the staff. We're in a bit of a perfect storm, as you know. We've got recruitment and retention difficulties. Post-pandemic, health visiting seems to be quite difficult to recruit to. I think there are increasing numbers of safeguarding cases, which again is impacting on workload. They're a really, really important profession, and I'm not just saying that because I'm a health visitor, but they are. They are the people who safeguard children in the early years. They are a truly universal service, and they are an opportunity to provide the best start of life in life. And if we're going to make any difference to children in terms of access to things like neurodiversity pathways, actually the health visitors are where we start. So I'm really invested in making a difference with them. I've given my commitment to Faye personally that I'll work with them to look at how we take the learning from the listening exercise into a plan that's developed with them, not to the side of them, and that we do that in a way that really starts to try and tackle what I think are some of the root causes. So I'm working very closely with Faye, as is Linda Alexander, my deputy, and absolutely George will make sure we feed back to yourselves and Faye about the progress.
Again, yeah, I'm aware that things are going on, and yeah, I fully support that, and I encourage that, to be really honest. It's not going to be a 5-minute fix, but people need to see those movements and changes happening.
They do.
Paul and then Pippa.
I think, first of all, it's really important that we send the message that our role, we have a duty of care over all the staff. And I think it's very important to say that we value, appreciate, and we support the staff and the work that they do. We also need to take into account the demand and impact on the service has been phenomenal, and therefore the number of complaints may well have excelled because of the situation. But I have been reassured as a member of the People and Culture Committee that the number of investigations and the process and procedures have resulted in quite a significant drop in the way things were approached in a previous time to where we are now. But I do think that from what my recollection of the meeting that I attended was that the processes and procedures were being looked at in a fair and reasonable and proportionate way, and that that particular issue of immediately going to an investigation, which can be then go on for forever and ever, had been revisited. And there was reassurance, I think, Sarah, that in fact that was being looked at to make sure that whatever the situation was, the scenario was, it was kept to the minimum amount of time so that there was an outcome quickly, as far as is possible, so that then any lessons learned can be moved on. If there are no issues or problems, then the matter's dropped, etc. But I do take on board what you said, George, and I think our duty is to ensure that if there are any issues that are raised, that they are dealt with as soon as possible, and that actually they should be dealt with reasonably and proportionately. And I think that that does involve a consistency and standardisation across managers and their styles and approaches, and I think that it may well be something one needs to look at in terms of the approach to dealing with a situation, so that one person dealing with it in one scenario is identical to the other to make sure there is a consistency there, rather than people thinking, well, if I was being managed by that person, I'd get a different outcome, or it would be a different approach. And sometimes experience comes into that, or knowledge and understanding of the organisation. But I do think actually it's very important for staff to complete surveys, to provide feedback, and we've got ward visits coming about, where we are going to meet with the staff and listen to what they've got to say, listening exercises. So I think what is incredibly important is I think that we are trying to be a listening organisation and take on board, but we do need people to communicate through the surveys, because sometimes the surveys have been, or the results of surveys have been about 15–20% returns. We need to make sure that staff are telling us so we can pick it up, rather than complaining to you but not to us. That makes sense.
It does make sense. I will say though, there are still staff out there that are too afraid to actually put their head above the parapet. In other words, it has to come through the union for that support, because they're still afraid of the potential consequences. Now, you keep on encouraging them or what have you to, that, don't worry about the consequences. Those are not going to happen, because you have people like yourselves, if I'm going to be honest with you, that will come down and tougher on the person who was making those threats rather than the individual who raised the concern. But there are still a hell of a lot of staff that are afraid to come forward personally. And I think that is a big concern.
Well, I think you need to have conversations with those staff, and we need to have conversations with the executive team or the executive lead of those to say there is an issue and that we need to raise, that needs to be raised. We need to be able to deal with the problems so that the staff can continue their work feeling well supported and advised, etc. But equally, I think we've also got our role as duty of care, and my worry is the disconnect currently between the demand and increase in what staff have been asked to do, which I think has got, because in terms of sort of the waiting times and people being anxious and questioning and all sorts of things, and going into the sort of accident and emergency and all those sorts of things there, that we just need to factor that into the scenario as well. But I would encourage you to encourage members to have conversations that can go to senior level, so that if there are individuals who are causing problems, then they need to identify it and conversations had.
Do you want to add something, Sarah?
Yes, just to pick up, I think the piece of work you're describing, Paul, is the Avoidable Employee Harm project that Wellbeing and the HR team have been working on together. And we've worked very closely with George, Louise and all of our staff side representatives in developing and talking about how we do things differently. Our partnership colleagues were on our first training event, and we continue to train managers internally in terms of the approach which you described. So that's work that's ongoing. We've had some really good positive feedback and results, the work that is ongoing. And just to briefly bring us back to health visiting and links with partnership working, having those local partnership forums, and it's positive. The Family and Therapies division are probably more ahead than any other division in terms of re-establishing, I will say, because they had one prior to COVID, but re-establishing their local partners.
Thank you. Pippa and then Louise.
We talk quite a lot about prevention agenda in the community and the public and the way they're accessing healthcare in the future and being, as responsible as they can be for their own health. And actually, it's health visitors, healthcare support workers are the people who come from our communities, who have the greatest voice with people within our communities. So for me, there's something about the value and respect that we have, and actually us understanding that these are our greatest advocates, I think, and that means us being able to offer a level of support for staff who are at the coalface, as you put it, and that's not always easy. But I think there's something about the message that we send out as an organisation about the value that we place on the work that people are doing. And also that they're not just getting training to be managers, but also they're getting training in the messages that the conversations that they can have with people in their community that support
the future of the health board and their own future career development. So the peer groups, I think, you know, the forum's a really great idea there. But for me, there's just something about us recognising the huge amount that can be offered, and then there's something around, you know, how do we support this particular cohort of people to be the best they can be by offering them career progression if that's what they want, or if not, supporting them to be the best they can be in their particular role.
Thank you.
Yes, I fully support. I mean, I still encourage the support from the managers as well, to be fair, because they have a difficult job. I don't deny that from you know, especially from the public as well. You know, they're getting bombarded with things. I think it's. And I will honestly say that we have some damn good managers who do engage with staff at an early stage, probably before the trade unions, which I would certainly encourage. But I also encourage those members of staff to contact their trade unions as well if they wish to do so. You know, I fully support. It does look as if I'm trying to single everybody out as a manager being absolutely rubbish with the job. They're not, to be fair. Thankfully, the vast majority are very good at their job. Probably need a bit more training or whatever. I don't deny that. But I just think it's just making sure where I think you all know there's certain hotspots or whatever that probably need to be deep dived or whatever to sort of resolve some of the problems or try to improve the situations there, and health visiting as well as the people, to be honest. And again, I agree with what you're saying, is that work is being done, and you know, hopefully it'll proceed and people will see the benefits of it as we move forward.
Thank you. Louise?
Oh, thank you, Chair. Yeah, and thank you, George, for your report. And there's a lot of good things going on within partnership working, and the people plan is part of that, and we'll have something on that later on, won't we? I suppose my main concern is that we are having the health visiting being a good example of something coming all the way to board that really should not have come to board. It should have been dealt with elsewhere. It should have been dealt with operationally. We shouldn't. And my concern is how many other things are going on in the organisation that are not being escalated. We're not aware of them, and how many staff feel they haven't got a voice to be able to voice their concerns about the areas that they work in. So I suppose although it's reassuring that George is able to bring that information to us, and we're now doing something about it. The reality is this has gone on for quite some time, and really I don't feel that's good enough. That it should have had to come to board. I think it should have been dealt with a long time ago. I think staff should have been listened to a long time ago, and I think we should be concerned that there might be other areas inside this organisation that is in the same place, and we might, in a couple of years' time, that issue come to board via the trade unions, and I've just got slight concerns about that. I probably need some more assurance that maybe we're working a little bit harder to make sure that some things are resolved, especially with the loss of staff that we've had in this particular area.
Thank you, Louise, and I would absolutely agree with you. It's imperative. Did you want to?
Yeah, I think just that whole issue of, you know, when making sure we're aware of issues and staff feeling able to speak up. You know, there's no doubt that, you know, since, you know, just starting around, reinforce everywhere I go about, you know, an open and honest and transparent culture that I want this organisation to be. And like you say, you can say that, but how do you test it? How do you make sure people got the opportunities? Because you do pick up, I think, as George says, there's areas of excellence, and you do pick up areas where, through the drop-ins I've done of visits, you do have, you think, I'm a bit concerned that people feel like somebody's decided to come forward and represent a group of people. So I think there's a couple of things. So one is about visibility. So, you know, sometimes don't just do planned visits, and we all as executive team trying to go out and about and drop in, and it gives people a chance in an unplanned way to be able to share. Trying to encourage all levels of managers to do that as well, not just us. So make sure, you know, those who are in the divisional teams, director teams, do you know absolutely what's going on in your area, and trying to encourage that. I think that training of the managers that George said has been a key theme that I think has come up through the TUBEB. You know, we've already been trying to look at how we invest in directorate managers and then the managers underneath that. And I know that's a key part of the OD agenda, that we need to make sure these people get skills, because it could be they're worried about their job and that's why they were here in a way. So how do we, and there's a broader piece about culture that we've been having a discussion as an executive team and keen for us as a board in terms of how we start trying to influence that culture across the organisation. And the other thing which Sarah was putting her hand up is something that's been developed, which is, I think, through a QR code approach, which is about reinforcing that ability for people to raise concerns confidentially if they want. And this is how to do it, and make a bit of a bigger launch about reminding people how to do that and encouraging them to speak up if they're worried about something. So there's a number of things at various levels that we are doing to try to reinforce that culture about, you know, I was in Neville Hall on Monday, and as a result of one of the drop-ins, one member of staff came forward and shared concerns. Jen picked it up. We followed it up with this specific listening exercise. We went back there this week, fed some of that back, and really tried to get the message as much as you can to say, ask us anything, say what you think is important that we might not always like it, but it's important that we hear the truth. So, you know, you can't fix this type of stuff overnight, can you? But this constant focus and trying to encourage that, give people the opportunity to speak up confidentially or openly, and then understand the root cause. You know, like you, I'm quite concerned with the health visitor issue. You know, there has been some intervention about the listening, but, you know, something that was quite unsighted. And as somebody who sat on the board for a long time as well, so I completely support those concerns. And there are a number of things we're trying to do, but welcome other ideas how else we can go about building that open, transparent culture. Thank you.
Final word from the
It was just almost back to the health visitor piece. I think sort of two things for assurance. It is disappointing that it gets, this has been unsighted, but I think just for assurance, both Jen and myself have spent time with the teams as well. It shouldn't just be at board level, in my opinion. I think that needs to be at all levels sort of for resolution. But in terms of, I think, when we've got the results of that listening exercise and we've got a clear plan, I think for assurance, George, I'll ensure that that is agendaed for each divisional assurance meeting that I have with the division, with the expectation. I know Chris has reached out for a discussion about how we resolve this, to make sure that we are resolving and dealing with the issues. I think part of it is confidence that when people speak up, it will be acted upon. I think changing that culture from maybe where we've been historically, and have people having that confidence that we will act when they've been as brave as they have. But I can categorically say in multiple forums, certainly this week, there has been positive reinforcement from exec team members about people speaking up if there are patient safety and staff wellbeing issues at risk, because we are very serious, I think, as an executive team around dealing with them and resolving those issues. So I think just for assurance, I'll ensure that is agendaed for each divisional assurance meeting until I've got the assurance that I'm happy operationally. We're on top of it and treating our staff as I would expect our staff to be treated, and happy to provide those updates via Trade Union Partnerships Forum if you feel that's appropriate, or separately.
Thank you.
Can I just
Yes,
make one?
certainly.
I will say, to be perfectly honest, and I'm going to put the onus on you all, to be honest, is that meeting staff is not just a handful of people, it's all of you. And I honestly believe that you should also make the effort to drop in and speak to staff directly, rather than relying on the chief exec, the ward, you know, the nurse director and so on. It's just to get a bigger picture of what is actually happening out there, so that at least then you could be their voice piece as well, to bring back to board and to try to get things resolved.
Thank you, George. We are very, very, very anxious to do just that.
Good.
Circumstances, as you know, have prevented us getting out as much as we would have wished. And that is why the visits that have been arranged, etc., and we do individual visits anyway, have really started because we did miss not going out there. We felt we were lacking something.
Yeah, no, that's right. Yeah.
So yes, I'm afraid we're going to be around the walls and in the community, pestering the life out of the staff.
Linked to that, I know the last one you did at Neville Hall, I know Sarah sent the invite to myself and Louise, to be fair, but yeah, we're quite happy to help support that, to show the partnership working is actually there as well.
That's grand. Yeah. Thank you very much, George.
Can I grab it now?
You can go. Yes, thanks ever so much and I have to say, having met many partnership councils, I always find that this partnership council is constructive, objective and really, really helpful. Thank you.
Yeah, as I said before, I'm not a shirt and tie person, as people know in this room. So
I know.
I won't take my tie off. I won't take my shirt off because I don't want to upset everybody.
Thank you. Thank you, George.
Okay, thank you.
Thank you. Can we move to 4.2 stroke reconfiguration, please?
Sure, we can contain the excitement of George stripping off for us, but right, on to more serious matters, I'm afraid. So the board will be very well aware of some of the challenges that we faced in relation to our stroke sort of delivery. Just as a really high level sort of reminder, our current configuration is that we've got a hyperacute stroke unit at the Grange, constituting 15 beds. And then our stroke rehab beds are split across our ELGHs, so 15 beds in YYF, 24 beds in Moor Gwent and 24 beds in Neville Hall, respectively. You'll also be aware from some updates that you've had is that we've hit the buffers with staffing at not infrequent levels. So I can cite in particular two instances where we've not had sufficient numbers of therapy staff. That was a considerable safety issue. Obviously, stroke rehab is a very important element of the stroke pathway and optimal patient outcomes. And we had to move our stroke rehab services from YYF and equally medical staff provision at Neville Hall has been problematic for us. Safety and sustainability remains at the heart of our it's the holy grail, certainly for me in sort of my role. And the paper that you've got as part of the pack is a proposal that the teams have put together following a pretty detailed option appraisal session that they ran. We had teams come together from all professionals, all sites were represented to go through an option appraisal in terms of what our configuration needs to look like. It is an urgent service change because of those staffing sustainability issues, but we've tried to do this in the most planned way we possibly can, given the burning platform we've got on staffing in particular. There is much more detailed information contained in the appendix in relation to this, but the outcome of that effectively was that the preferred option by some way or by some margin was that we should reconfigure our services for that urgent service change with further work to be done on engagement to our hyperacute stroke unit in the Grange, and that for all of our stroke rehab beds should be configured at YYF site. Just for further information, I think it's really important, we've had the independent review of stroke services that we commissioned GIRF to undertake. I know Peter briefed the board on that, and it was their recommendation that we should consolidate our stroke rehab services as well. The ultimate proposal for that urgent service change is that we, in the first instance, aim for a reduction in bed base from 78 beds down to 70. I do think that there's more potential there, but given that the time scale for that change is likely to hit one winter, I think the team have been a little bit conservative around the winter buffer, but happy to pick that up in questions afterwards. We have a duty to engage with our staff. Interesting to follow on from George from an organisational change perspective if we're changing their base, and that's been factored into the paper. We have had very early engagement with our trade union partners and Llais on this particular issue, and Llais and Gemma in particular have completely understand the rationale and have been sympathetic to this and recognising the urgent nature of the change required, but happy to engage with us thereafter pending conversations today. So just a request from me, please, to support the recommendation following that work for the urgent service change to a reconfiguration of our stroke services to provide HASU at the Grange and YYF to become our prime stroke rehab facility. Noting that I think that there will be further opportunities on both bed base, some of the community therapy intervention as well. I think means we should be looking at taking a reliance off bed bases, how we deliver stroke rehab. And also I think noting that the potential change with the lead times that we've got, although recognising that can change, is that this is likely to hit December to January, but more than happy to take questions at that point.
Thank you, Leah. Questions? Peter?
Just to add some thoughts, really. Thank you, Leanne. Leanne covered most of the things I would have said, really. I think in terms of the journey that our staff have been on, and obviously I meet regularly and talk regularly with our team on a multi-professional level, not just the therapists, and that's really useful for me to gauge where they are with this. And you know, they really welcome the GIRF review. They live and breathe this on a day-to-day basis on the front line. They know that it's really difficult to provide the high level of care that they aspire to across 4 sites, as we try to do at the moment. So they know that, they see it every day, and they talk to families, and they can see how difficult that is. So they know something needs to change and something needs to improve. And we've taken them on that journey. I think probably the bit we need to be very mindful of is that we do protect them a little bit from the fragility of the service and the urgency. They know about the quality metrics, they know about the requirement for therapy hours, but I think it's really important, after whatever decision we make today, we actively engage with staff, as is our intention. But an important message is why we're doing this urgently, because I don't think that will necessarily be appreciated. So that's based on the feedback that I'm collecting when I'm talking to staff. So we've got to keep that in our mind, that they won't be surprised about the need to change from a quality perspective, but they might be surprised how urgent this is from a fragility point of view. So I think it's really important that we do not underplay that. Fragility element is going to be really important, not just in terms of how our community receive it, but how our staff receive it as well, really. And from my point of view, and I know other colleagues will say the same as well, whatever decisions we make today, and after that, we need to then launch into some really full-on engagement with our staff, really. It's going to be intensive, but I think we're all up for it. And from a personal level, I'll be clear in my diary to do that. I've been in a conversation with our CD for therapists this week, anticipating this discussion today, and just kind of trying to gear up and think through how we might do that and how we might engage with staff. So we've got some ideas around that, but I think that's going to be really an important element to doing this successfully, really. That's kind of the main thing I wanted to say.
Thank you, Peter. That was really helpful and important. Are there any questions? Louise?
Yeah, thank you. Thank you for the reports and everything. Just one question, it won't be any surprise, it's the usual question I'm asking, is because I know there is urgency around this, and I support that, and I think staff are well aware of the urgency, I think, because some of this work was actually going on during COVID.
I think we protect them sometimes.
Yeah. So I know, so they were well aware that stuff was going on. As you're saying, it's going to escalate rather quickly, isn't it? So my concern is we cover the rehab side of it in here, and about maybe adding some extra equipment and space. I'm just bringing up the same old thing about rehab space and the ability to deliver on rehab quickly and not have to wait once this move has been done and then wait for equipment.
Yeah.
Can we have assurance that we're going to link all that in quickly together, that we're not compromising any patient care while doing this? Okay.
I think we have a great opportunity actually here, in terms of, if we do this properly, we can create a real centre of excellence for stroke rehab. Stroke rehab is a real specialist thing. It's not general rehab, and we must not miss the opportunity now to really invest in those areas to make them the best rehab facilities they possibly can be. And all that stuff, Louise, about the equipment in the space is really important. We are having to move urgently here, so we won't have all that in place for day one. But what I am really keen to do is that we have a programme now that we take forward that starts to build and develop that offer into the specialist rehab. And included in that is what Leanne referred to in terms of the community rehab as well. That needs to also be part of our improvement journey now in terms of getting that community offer much more robust, much more solid, so that people can move through hospital in the soonest time and get get home and start their rehab at home, because that's where they really want to be, and back home with their families. So it won't all be in place on day one as we make the move, but it is the start of a journey that we're all committed to about, really making this improvement for stroke. It completely ties in with our stroke improvement plan that's on the back of GIRFT as well. So we have some momentum around that already anyway. So, it's a serious commitment.
Thank you. Can I ask about the county bed? Yes. Where are they going? And will any beds be left in YYF, and will they meet the needs of the population?
So for your assurance, the teams are currently working at there are some quite significant interdependencies in terms of our overall bed plan with this as we move potentially sort of services around, and that had to be factored into some of our conversations and considerations around this. So there have been some very detailed conversations with the team at YYF about how we meet the needs of the population, particularly for patients that are currently in sort of COTI beds. We know that there are roughly 2 wards full of patients that don't need to be in YYF, actually, I think, in terms of the medically delayed. So there are, off the back of this a decision today, there will be a requirement for us to map out the wider bed base, assess it with some of we've talked a lot about sort of the financial situation already, and understandably, and our drive and our need to take down our bed base. And I think it fits sort of very, very much so with that. So there is a detailed clinical model plan that is currently being worked up to sit alongside this, that ensures that the needs of our population is met. But there is a more detailed sort of, that plan will need to come forward, I think, pending sort of today's decision.
I don't know that I've had my question answered, really.
We will have to replace the COTI beds. Some of those COTI beds may well need to be moved to the Gwent for those with a true care of the elderly requirement. We need to take the opportunity, sorry, I've waffled a little bit, Anne.
Sorry.
For that. We will need to take the opportunity, I think, to take patients out of beds that don't need to be in bed, so that those with a COTI bed need are met as best they possibly can at YYF. And we are looking to support, I guess, the frailty community offering, Caerphilly in particular, to support those patients in the community. So it's a multi-pronged approach in relation to sort of the beds sort of required.
Thank you. I think it's important that the board receives an update report, which can absolutely assure them that we are going to satisfactorily meet the needs of those patients, as well as improving stroke rehab, because it's important, isn't it?
Yeah, I think so I think what we're saying is, overall at the minute, the bed base will stay the same, although we are going to try to reduce the bed base not the stroke one, but overall we'll replace us with COTI, because we know those patients are in those beds now. We are going to try, on the back of all the discharge work and the frailty, to reduce overall need for beds in YYF, but we will have the capacity with free up at Neville Hall and the Royal Gwent to re-provide the COTI that we need, and just the detail around that needs to be made really clear, and maximise the opportunity this could offer in terms of being able to take beds out if that's feasible, through a better offer in terms of medically fit patients. But they will be re-provided in the event we don't think we can do that in capacity we'll vacate to the other sites. Right, so that's right.
Now I've got Ewan, Paul, Pippa and Shelley.
One of my questions is just following on from that. If we are moving people, and obviously because we're consolidating the services, we don't quite need the number of people, etc. So there is a, blenders terms, there's cost reduction there.
Yeah.
But it sounds as if then we're putting that money back into the COTI beds, in which case we must be increasing the staff in that area. So are we pushing this issue onto somebody else, or why do we need the extra staff for those beds that are fully staffed at the moment then? I don't quite understand the finances.
So at the moment, there is, contained within the paper is an estimated, although that's based on substantive staff, saving of approximately, if we close the beds from 78 to 70, of about 627k.
Yeah.
That's based on substantive staffing. My personal view is I think that's probably understated, because we know that we've been incurring agency and premium rates because of the fragility of staffing. So I actually think that there's probably sort of a greater benefit. There is a, because of the overall demand on COTI beds, within the stroke bed base at the moment, you get, we use the phrase outliers, it's not great, but a mismatch in sort of the requirement. If we get empty stroke beds, as you can see from the occupancy data, we don't actually use all of those beds, but the system use for stroke, let's just qualify it with that, but we sometimes and often use those beds for COTI patients. So understandably, the paper talks about the requirement for stroke beds for at 78 as it currently stands, and the proposal for stroke in particular is down to 70 beds. If we can hold those 70 beds and not continue with the outliers on COTI, that becomes a cash releasing saving. And that's the piece that we need to work through in terms of the bed base. You know, what does the rest of the bed base look like to be able to take that out from in terms of cash releasing? My personal view and my plan for this is that it should be cash releasing, because we've got a not inconsiderable number of patients in our beds that don't need to be there. And actually, in terms of the consolidation of staff, not just for stroke, I'd like to think there'd be some benefits around the further reconfiguration, because our staff are spread across our processing, our length of stay is extended. So whilst the paper talks about reprovision of those beds sort of from COTI, my plan as part of this would be to take those costs out.
Okay, so we don't think we're moving the issue then into another department, if I can call it a department.
Correct. And both of those departments anyway sit in the same divisional from an assurance perspective anyway. It's really hard to just isolate stroke because of how the rest of the services are configured, and our beds are not nice, neat specialty sizes, which means that. But
obviously you're moving all your specialty into a couple of places.
Correct.
And leave your non-specialists looking after some of the other patients, I guess.
Yes.
For a non-educated person like myself.
Yes, but the COTI services that we've got, in my opinion, because we're not spread into sites that aren't providing those already, should be able to cope with that.
When would we get that assessment through? When do you think we'd be able to work that out?
This forms part of that plan.
But getting those figures through, when would we likely see that?
I think that needs to be.
So that kind of financial assessment around what
sure.
this is doing for us.
We've got a financial plan in terms of bed closure anyway, that we have to progress. So I think we've got to have that bed plan finalised for autumn, particularly as we head into winter, from a safety perspective.
So will that include then the other costs that are in here? Because obviously we're talking about relocation costs both ways, I guess, from the consolidation and the moving people out. Any ideas on what that would be?
That hasn't been factored in at the moment.
Okay, and the extra equipment that's mentioned in here, is that a longer term thing? Do we have budgets for this, or have we got any idea on any of this?
We will undertake a stock taking of the equipment that is missing. My expectation would be that we are currently providing that service over 3 wards. I bet you if we did a stock take that we've probably got those across the 3 wards in terms of bringing the equipment together. The fact that they're on the sites and maybe pieces of equipment have wandered or been borrowed, I think we need to revisit sort of and assess that.
Yeah, I'm just trying to understand what we're signing off on today, how much extra budget we're looking at, because if the release of the beds budget is frozen almost because we've got that, there are the relocation costs. So we are signing off on additional not budgeted costs, I assume. today, which we don't actually know, I'm guessing, or
I-
are we?
I don't believe, and I'm confident that with the offset in the cash release in saving that we're getting, Ewan, that we will incur additional costs over and above our current sort of base. And in fact, my plan will be to make cash release in savings off the back of this move, albeit that's not the primacy of the purpose.
No, I get that one. It's just trying to understand what the quantum of some of the costs, because obviously relocation will be a today cost. Freeing up the beds would be a longer term saving. So we are putting cost in with hopefully some release of costs later on.
Well, I think that there will be an immediate release of costs off the back of the premium agency costs that we're currently incurring.
Okay, but
so my commitment to you is that this will not cost additional money over and above the quantum we're currently spending on stroke. And my plan is that this will be cash releasing.
okay, so when would we see that then? When we get it? Okay.
Because that will allow me to do the more detailed bed modelling. It's quite difficult to do that in terms of the plan sort of prior sort of to the decision for an urgent service change.
Great. Second one, if I could, I think this highlights what we were talking about earlier as well, because we describe this as a temporary move of things. It comes back into that plan of what our longer term estate service provision is, kind of thing as well. So I guess this is almost a semi-permanent move at the moment rather than just a temporary one, or do we have a finite plan to it?
I think there are some other interdependencies in terms of what's happening with site that we'll pick up in sort of the in-committee session later on. I don't see it as being, and certainly if we consider it to be semi-permanent, I don't think we would be suggesting engagement with both FLICE or our staff via the OCP process. Okay. So and part of the reason we've had discussions previously about whether we do this in a more incremental way, but I don't think we can do that to our staff given, I think, the fragility and difficulty that we're experiencing. So I think whilst FLICE have been supportive of the urgent nature of that, and that's the engagement that we've had with the teams and what's driven us to bring this paper forward, I think that if this is supported, that is a permanent change, and then there are wider system sort of conversations that we need to have around sort of estate and configuration, partly the bed plan in the autumn. I'll make sure that is brought forward. There's been a request off the back of sort of the LGH configuration piece anyway, that will bring that together to give the board assurance that we have a plan that is quantified both from a workforce, service model and financial perspective.
Okay. Can I just add to that? I just think we basically have turned this proposal around quite quickly over the last 3 months, recognising some of the urgent staffing issues. Also seen as an opportunity to absolutely sustain the workforce, improve quality by centralising. It's evidence-based, and you know, based on what we know, it should actually make us more efficient. We can see how we can bring the beds together. There's 40 patients in stroke beds now, so we're trying to reorganise the decks in a better way. But ultimately, we should be able to be more efficient as a result of doing this, providing better quality care. We're working faster than we normally would work on some of these things at the minute. We've got other examples where we're making quicker decisions because of the context we're working in. So there's quite a bit of work left to do around just the operational detail behind this. I don't think any of it compromises the decision, or, you know, we're not clear about how certain things would work. Things like relocation expenses, there will be some cost, but in the scheme of the opportunity it brings, you know, that's why they're not all bottomed out. But what we didn't want to do is lose the opportunity to get the decision, get the pace we need to get this in place in advance of the winter, to drive those quality and workforce sustainability issues that we're facing, and then also in parallel do the work with FLICE around that kind of longer term piece. So I suppose just the context with which we're working in, I feel that we have pushed this through quite quickly, but with sufficient operational detail to make us feel confident that we can now go to the next level. Thank you. Paul?
I mean, the key question for me is what is best for the patient, and there's no doubt in my mind that what the proposal on the table, which there's been some the options appraisals, I think this is a decision I would wholeheartedly support. I think having a centre of excellence is something which is incredibly important. And I think that the whole issue of stroke has been one that has been discussed repeatedly. The GIRFT work indicated quite clearly what the direction of travel should be. I think what we're picking up on is Peter's point about the rationale and communicating to staff. That's important. Equally, what Louisa said about the making sure everything is in place so that it's not going to be, what are we waiting for? So I think that taking on board what Nicola's just said, which explains to me as to where we are, is that yes, if we make a decision today, it's one we would probably not normally make at this stage, but if we do make it, and I would support the decision, then we need to make sure that there is a plan, that it is arranged, sorted and actioned very quickly, so that all the dominoes, I suppose, are in place rather than being knocked over, so that everybody knows exactly what's going to be happening by when, and that all the plans are there, all the materials are there, everything is ready, the staffing is available, and I think this is a great opportunity to actually sort this problem out once and for all, because I think the issue for me has always been the disconnect between the different facilities, and having one centre of excellence for this particular very important area of activity of stroke, I think is incredibly important with the rehabilitation support, because again, that's something that has been slightly piecemeal in my view, and I think this does give us the opportunity to decide on a direction of travel which is going to make it better for those patients who suffer stroke. So that I would wholeheartedly support it.
Thank you, Paul.
First of all, I guess a little bit echoing some of what Paul said around support. For me, this paper sort of falls into two pieces. The one is the really important work for stroke, and bringing it together. The consolidation means that we can offer, consistent therapy to people and rehabilitation. We can get them home quicker, and they can have better recovery. So in terms of the patient quality of their experience, I think that this proposal is absolutely the right way to go. And it concerns me when you split things across many sites about the inequity that can occur. So leaving that aside, the second thing that worries me is the COTI beds. And I know we've had quite a lot of discussion about them already, but if we're talking about 40 COTI beds at the moment at YYF, what we're talking about there is a consolidated service in effect, where the staff are dealing with a reasonable number of patients. What I wouldn't want to see happen is those 40 split for 20 in the Gwent, 20 in Neville Hall, or 10 in Neville Hall, or so that we end up with a similar challenge and problem for the COTI patients that we have had for the stroke patients. So for me, to read something that says the place for these people is yet to be determined concerns me, because I want to think of them being treated as a cohort in much the way that we treat stroke as a cohort. And so it's the only sticking point on the paper for me, is about making sure that we don't spend more money by splitting people up, but also that they don't get the same level and quality of care, because again, they would be subject to the inequity of being put across many sites. So it's really, whilst I support the paper, that for me, that COTI question is a separate question that we really need answered.
Do you mind if I come back on that? Because I think it's a really important point. We provide COTI across all of our sites at the moment. It's one of our mainstays services, really, I guess. The piece for me around that, though, I think, Pippa, is how many of those actually require hospital-based COTI services. Anne referenced in her sort of the number of patients that are delaying sort of in our hospitals. Some of those are within our gift. The work that Jen's been leading on discharge tells us that there is a great deal of opportunity available there for our population in the first instance, most importantly, but for us as a system as well, if we treat them in a different way. So, and I apologise if I'm not given sort of appropriate assurance that we'll treat that cohort of individuals as they should be treated, but I don't think that is via bed base. We must, you've heard me say before, and you'll hear me say again, we must get away from beds as being the main indication of how we're providing healthcare currency, because it's not, and I think some of the community rehab elements of stroke, as well as sort of the wider redesigning services for older people, is where some of this work needs to sit for us. So there is a lot of work going on. Having a firmed plan that we can commit to is not, and back to the point that Nicola's made around sort of timescale, is something we haven't got at this stage for this, but I am confident in the assessment that we have done already that our COTI patients won't be disadvantaged, and in fact we've got further opportunity, I think, in the wider system configuration piece.
Thank you.
Thank you. Shelley?
Most of my questions have already been raised, so I won't go into those. The one was in relation to the staffing, and obviously the consolidation onto one site, means that you will have safe practices, etc. Are you confident that the staff that are currently saying that they're happy with that will actually want to stay with the service, and we don't end up in a situation where people decide that they want to stay at, let's say, Neville Hall or Gwent, because they don't want to move, so they opt to go to a different place, which I'm sure they will have. So that's the one thing. Can I just, and the other question I had, it's more about the communications plan, because obviously this is going to be quite significant change for those people who obviously probably at this time are in our communities, like ourselves, thinking we're never going to need to be part of this service. But if you currently in your mind would be, for example, you go to the Grange and then you go back to Neville Hall for your rehab, just going to YY, I think will make a significant difference to people. I notice obviously there is an engagement plan, and I understand this is urgent and it's temporary. But if we're going to be saying, I hope, as part of that engagement plan, this is temporary, but it's going to lead to the permanent position. And it's about what we're going to be doing, because it says in here, for example, statement to be released. It says only if asked. I just think we need to be quite proactive on this, because this is a significant. I mean, I'll give my mother as an example. My mother was in Neville Hall, so I would assume that somebody perhaps near to me would be going to Neville Hall. There's a lot of difference for me between Neville Hall and going to YYF. Actually, it's irrelevant because I'm in South Powell, so they probably wouldn't be coming to any of them anyway. But do you know, I think there's a big issue, particularly with that cohort of patients who tend to be older, so they're not going to be as mobile. It's going to be difficult. So I know part of that is probably ongoing, but I just want some assurance about the detail around that communication.
So in answer, I think, to the first question, Shelley, I think our experience from the Grange opening is that staff select either on the basis of site or specialty. It's where their love is. We've had examples of people being able to walk to work. That's their prime driver in terms of deciding, versus those that are really committed. Not I'm saying others aren't committed, but they really love that specialty. So I think the fact, and we've seen it with, the approval of the breast business case, people will come and work in a centre of excellence because they select that. And part of the reason we've done the wider sort of option appraisal with a wider cohort of staff, I think, is to test that, because what we couldn't have done, I think, is put a paper here that we had no confidence that the staff would follow that service and continue and build on sort of their pride and will to provide sort of an excellent service for our patients, which I know they're frustrated at the moment. So my belief is that back to that centre of excellence, I think you build it and people will come, almost, I think, to support that. And that's why we've built in sort of quite rigorous sort of timescales around sort of the OCP to allow for that appropriate engagement. I think back to the travel piece for people and that engagement, Gemma is very understanding of the urgent service need, but the finer detail of this gets picked up by the engagement piece now ongoing. Sort of now there is a huge amount of work that underpins sort of that if a decision is made today that will need to follow in the coming months. That community engagement, people understanding what will happen to them if they get a stroke and the service that they can expect. Some of that for me is you may need to, part of the reason that geographical demand was factored into this in terms of the travel, the offset, it's like the Grange, when we did the modelling on the Grange, actually Llanfrecffer was the best option for us in terms of travel times. The demand in Newport and Caerphilly sort of boroughs in particular means that probably a larger proportion of patients may well benefit sort of from that. But equally, extended length of stay in sites, even if it was Neville Hall, for example, we would expect to see improvement in length of stay. So actually people are not having to travel for that. And I'll keep coming back to the community rehab offer. You know, ideally that rehab should, as best as possible, should be done at home, which actually means that there's no impact. So I'd like to think that the travel piece can be offset as a minimum by that, if not even enhanced.
You want to add to that, Jenny?
Just to back up what Leanne said, that I think the wider issue, I think, with care of the elderly beds is that actually there shouldn't be beds. There should be a service offer that might be a short stay, but might be care in the home. And almost the way we configure this, it's almost like trying to get everything into line, isn't it? To make sure everything works in progression. But we know probably if they need a bed, the best place is a community hospital. We know that community rehab, where they are familiar in their environment, is going to be the best place. So we need to look at enhancing our community services. So almost this is a continuum of pieces of work which are aligning to create the best environment for patients as close to home or in their home as their preference as soon as possible.
Sorry, I'm going to have one follow-up on the community services side of it. I understand and absolutely agree. I mean, I'm supportive of what you're trying to do, but you know, once this change happens now, you know, sort of summertime, whatever, is that community service in place to make sure that we are able to sort of move people to YYF and then get them home as quicker than we are now? Sorry, I don't know if I'm supposed to be or not.
Our community neuro rehab service, which is the service we have in Aneurin Bevan, that takes stroke survivors out of hospital and starts their rehab at home, is an exemplar service. It's best in Wales. We have been described as a pathfinder service in terms of our CNRS service. It really is amazing, and we're really proud of it. It's not big enough, though. You know, we know if it was bigger, we could do more, and we learned that during the pandemic because we moved therapists into that service, and they were able to get people home sooner, which of course everybody wanted in the pandemic. But there is a really sound basis to build upon, and the model is really good. At the heart of what CNRS do is care aims. It's all about the care around the patient, what matters to people. I've watched them, the way they talk to patients, the way they talk to families to understand what the needs are. And that's where you get that really personalised care and where care closer to home genuinely starts, really. We mustn't forget that hospital rehab for stroke is a very specialist intervention, and it really does work better on a consolidated single site. That's what the GIRFT evidence told us. Interestingly now with our staff, in order to provide a service on a day-to-day basis, it's so fragile. We are continually moving staff around, swapping and changing. Somebody goes to Neville Hall one day, they go to the Royal Gwent the other, just to keep it going. We would avoid that in the future if we consolidated on one site. I don't want to preempt the conversations we need to have with staff. We'll get all sorts of feedback as Leanne described, and we must listen to that, and it will be different. People will have different wishes and thoughts, I'm sure, but I believe it will be less disruptive for staff, and it will become a much more attractive place to work. Something not to forget is when you've had a stroke and you're on the road to recovery, it's incredibly frightening, and that's one of the features of stroke. It's frightening, and we know that your family being with you is really helpful, and that will be more challenging if you don't live locally. But we've done some really interesting work. It just so happens at YYF where we're using stroke survivors as volunteers to spend time on the ward, talking to stroke patients, supporting them. It's like peer support, and it's working really effectively. We've got a really interesting model emerging at YYF. That it's just coincidental it's YYF, but we're trying to think of opportunities to address that need for stroke patients who are genuinely frightened and they just want some support. And we just keep that at the forefront of our mind and make sure that whatever changes we make as a result of this, urgent pressure we're under, that we don't forget the patient and we look after their particular needs, which we, of course, we will do.
Thank you. I think we've had a considerable discussion on this issue. I would ask the board whether or not it is content to approve the recommended option, which supports the consolidation of the stroke services as a matter of urgency, so that we do not miss the opportunity to consolidate the service prior to the winter. But that we also agree that we will have a much more detailed operational plan back to us in September, which will describe explicitly the whole of that stroke rehabilitation service, to include the healing ward, and also the care of the elderly model that will be affected as a consequence of the change. Are we happy to do that?
Yep.
Yeah. Thank you. With cochlear and bone conduction hearing implant engagement and next steps.
Thank you, Chair. So this paper you have before you has been prepared by the WISC, so the Specialist Commissioning Committee, and will be going to all health boards in this cycle in July. So just a bit of a recap for colleagues' awareness. Until 2019, cochlear implant services in South Wales were provided from 2 centres, so Princess of Wales in Bridgend and UHW in Cardiff. And, you know, echoing the conversations we've just had, in 2019, an urgent service change was required to consolidate the POW, the Princess of Wales service was fragile and had to be consolidated urgently on UHW, with the intention, following the same process we've just talked about, to do the proper engagement post the move, make the service safe, and then engage in terms of on a longer term solution. That was delayed because of COVID, and then in September 2022, you will have received a report outlining an engagement plan to do just that, so to pick up the engagement that had been required post the 2019 move. So the purpose of this report then is to share back to the board the outcome of that engagement, and hopefully you'll see that it shows there is significant support. 74% of respondents to the proposed model, which is for a regional centre of excellence in South East Wales. This isn't about location yet, this was about model. So support for that, but really picked out some of the themes, some of which we've rehearsed now in terms of access, travel times, some issues around, specifically around access in terms of parking, etc. So the report talks you through some mitigations to those issues, but the Joint Committee of WISC has received this and recommended, in terms of the next steps, that WISC, of which we are a partner, proceed with the detailed planning around the Centre of Excellence in terms of the location of where that may be, and that work, and agree in terms of the process with Llais, and a final report then coming to the Joint Committee later in the year. So that's the only detail I wanted to sort of go into in terms of the report. So whether Rob wants to make some comments in terms of from a commissioning perspective, but I think it's fair to say, so our communities are accessing the service there at the moment, whilst we do provide some bone conduction implants in the Royal Gwent. The numbers are in single figures per year, and so from a commissioning perspective, it in terms of stacks up for our communities and our pathways. So it's presented before you now to ask you to note the report and the outcome of the engagement, and to support the next steps in terms of consultation on the preferred location for that Centre of Excellence.
Thank you, Hannah. Are there any comments or questions? I think this is reasonably straightforward, because the need is for one centre, not more than one centre. Yes. And I think we're just writing the planning of the past.
Yeah.
In this. So are we happy to proceed along with the suggestions and carry on to the next stage? Lovely, thank you. The People Plan Update 5.1.
Thank you, Chair. The People Plan, which was agreed at board last May, is just over 1 year old. So the purpose of this paper is to provide board with an update on the progress made so far. Apologies, I think when the paper was converted into PDF, the infographic seems to have gone a little bit blurry. I was having some trouble reading it last night, but I've shared a clean version with Bryony so we can update and share that along with the paper, along with the additional other papers for board. So there's an awful lot of information held within the paper. There are 23 broad actions contained within the People Plan, and those for specific delivery are noted in the paper for the first year. To give some assurance, progress on the key themes of the People Plan have been regularly reported to People and Culture Committee. And when we developed and launched the People Plan, we gave assurance that we would have a delivery tracker. The delivery tracker is live and well and is considered on a monthly basis by the Workforce and OD team. We discussed there what's gone well, what's not gone so well, and how we might need to reprioritise those actions to meet the needs of the organisation, which often can be more fluid. So there's lots of detail within the paper. I'm not going to go through it all, but I would like just to highlight to you some things which have gone well, some things maybe which are off track, and also something which will be more of a forward look moving forward. So firstly then, just in terms of things which have gone well, as you know, we unfortunately did not receive funding from Welsh Government in terms of our full model of the Employee Wellbeing Centre of Excellence. But to have our own internal response to that, we have used that model and sold our skills and expertise to partners across the region and indeed to England as well. We have, from that, been able to generate income in the region of £200,000. And from that, we have been able to recruit additional counsellor, and we're currently out to advert for another counsellor to support the increase in demand, as you will see from the infographic on our wellbeing team. You'll see from the infographic that our waiting list has increased from last year from 16 to 27 weeks due to the increase in demand. But just to give you assurance that no one is sat on that waiting list with no support. There are a range of options presented through telephone triage and a choice given. So the people who are on that waiting list have chosen to access our services other than the services that we partner with for wellbeing support for staff. And in terms of outcomes from the wellbeing service, 68% of the interventions have a positive outcome. And just to give you a flavour of how that compares to general services, there's a 40% primary care positive for wellbeing services in terms of outcome measures. Where there are public services in England, that's reported around a 20 to 30%. So to have a 68% positive outcome is pleasing in terms of the benchmark for similar services. We've spoken already about the avoidable employee harm work. So this is really work that's been led by the workforce HR team in support with Adrian Neal and wellbeing team, really looking at how we change our behaviours and our approach to formal employee relations activity. And with that, we have held many training events and we continue to do that, and with a change of approach, putting people at the heart of the policy implementation. We've achieved a 66% reduction in formal cases. That has seen an increase in informal activity, but as you'll see from the paper, we've highlighted a quote from one of our divisional nurse colleagues who has been instrumental in helping us implement the new ways of working. We're also pleased to have won national recognition through CIPD and HPMA, and we've also working closely now with HIW to launch this programme across NHS Wales. And we'll also be working with the Gwent Workforce Board moving forward to support that partnership working. We work closely with Cardiff University also on this piece of work, and in terms of looking at it from an economic angle, we've been supported from academic colleagues who estimate that the approach has avoided over 1,000 sick days and around £700,000 in costs associated with formal employee investigations. And we will continue to work on that theme, and particularly we will be looking at speaking up safely for our next phase of that project work. And we mentioned that earlier in terms of the trade union partnership paper. Recruitment, particularly for healthcare support workers, has gone extremely well, as well as for international and local nurses and apprenticeships. All of that work has really supported our ability to reduce our reliance on agency, but we recognise there's much more work to do there. And you'll note from the infographic the slight increase in medical vacancies, which is a significant issue for us, and I'll come on to in a little bit more detail. The leadership development, a fresh approach to supporting CDs, a fresh approach for our leading people offer, has supported more leaders to go through programmes of work, and also implementing a new approach to the Equality Impact Assessment. A formal evaluation will be shared with People and Culture Committee in due course. And we've also been able to increase the number of words that we've translated through our Welsh language team, a 27% increase from this time last year. Although we do still sit behind other health boards on the number of words that we translate, and we're working with external providers and looking at how we increase our internal offer to increase that even further over the forthcoming months. Things maybe which are a little bit delayed or haven't gone so well. We've spoken before about the Healthy Working Day. We've had some delays in initiating that research project, but you'll see from the paper that that's now in progress, and we will encapsulate that with our employee experience offer moving forward. Occupational health capacity has been challenging over the last 12 months due to some unforeseen maternity leave and sickness absence issues, and we're working closely with our occupational health colleagues and external providers to identify ways to increase that capacity. And I'm also linking with other health boards in our local area to understand how we might work together to support that capacity. Significantly, medical recruitment has been very challenging, whilst there's been some positive impact with our Tier 1 doctors. Having the middle Tier 2 doctors has been increasingly challenging. Leanne explained some of the particular issues. Neville Hall is a particular problem, and we're working closely with international recruitment to identify if those pipelines exist overseas. We know the Tier 1 pipeline exists overseas. The Tier 2 we're not so sure of. So we're working with HIW, who are leading a international recruitment event. We're also very much in contact with HIW in terms of our junior doctor allocation. We've had some information which suggests our allocation is lower than other health boards. James and I have formally written to colleagues in HIW, and we're waiting for a response on that letter, which was sent just a couple of weeks ago. So that's something we will be chasing up in earnest. Agile working continues to be challenging, but we've had some good opportunities for further discussions, and I see there will be plans moving ahead. And just to bring us on quite quickly to other issues in the paper, which will really set the foundations for the next stage of actions. building on our staff networks. It's been great to relaunch or re-establish and create new ones, but now we're working on identifying a framework to formalise those networks in the best possible way, so that we can really hear their voices and ensure that those networks make a difference. There's been a tremendous amount of work in the procurement of medical e-systems, which we'll take forward. And also we've been really fortunate to secure funding from HIW to be able to recruit dedicated support for talent and succession planning. No question, workforce remains our greatest challenge. It can also be our greatest opportunity. And just to note, there have been regular communications with staff throughout the previous 12 months to update them on progress with the people plan. And whilst I'm sure our communications won't have reached everybody, it has been really positive, because from each communication I've received direct feedback from staff and have been able to connect with colleagues across our health board who have come forward with fantastic ideas which we build into our plans moving forward. We're happy to take any comments or questions.
Thank you very much, Sarah. It was very, very helpful and important. It's good to see the progress that has been made in this people plan, to which George referred, obviously. Are there any questions? It's fairly comprehensive. Paul?
That's an observation. I think that just to commend the plan and also the equality, diversity and inclusion work that's been sort of moved on and supported, which I think is incredibly important at this time.
Thank you.
Well done.
Jenny?
Just to say, and coming back to what was said by George earlier, the important thing around speaking up safely is we connect it into some of the work around patient safety and quality, so that we're encouraging staff to come forward and raise concerns. That needs to be done in a psychologically safe space, so staff feel there isn't that sort of retribution for them raising concerns. So it's really important that we encourage. I've heard staff say things like they've been told not to use Latix, for example. So, you know, it's really encouraging those opportunities where we can encourage staff to come forward and then we can intervene and prevent harm. So very much connects into the work we want to do around a just culture and how we support safer working practices.
Shelley, did you want to raise something?
I just wanted to say the plan is really good, but also the way that it's been set out is really clear, particularly about what we've done. You know, this is and also things that we haven't done so well. So I just wanted to say it was quite a pleasure reading it.
Yeah. Yes, thank you. Ewan?
Yeah, it was just going back to the disciplinary investigations. It's good to see the actual reduction number of investigations we need to carry out. But in there, there's the 60% reduction in actual disciplinary cases. Which sounds a big drop then.
Yes.
For, you know, it seems a step change in it. Do we think that maybe we're too high in actually taking out formal investigation of disciplinary cases last year? Or do we feel that maybe this year things aren't coming through and we may be storing up issues for future?
No, so when we started looking at our activity, the evidence showed that we were commencing formal disciplinary investigations, which were progressing to a formal hearing, but not reaching any sanction. Therefore, we were undertaking investigations unnecessarily and putting a lot of effort from
so sorry, it's the investigation was coming out of the case rather than the case coming out of the investigation.
Well, the investigation would go to hearing and then there would be no sanction. So there would be no evidence to suggest through a protracted investigation
so our process in the past was a little bit broken. We were taking these investigations straight through to a case, even though there wasn't a case. Yeah. Okay, that makes sense.
Any further comments, questions? Well, we look forward to similar progress being made next year. Thank you.
Thank you.
Thank you and your team. The Communications and Engagement Annual Report.
Karen Newman is on leave at the minute. James Hodgson is on the call if there's any particular questions, but it's a fairly self-explanatory report. Karen and the team have put it together to capture the breadth of activity that's been going on around communications and engagement. As you know, we merged the communications and engagement team a few years now, and really starting to see the benefits of that now. We've been able to get back out into the community, which we have during last year. I think there's quite a big focus on prevention and population health now in our communication, but from dealing with press inquiries, social media, and then the work that we do internally around the staff communications is vast. I think the plan is to have a refreshed communications and engagement strategy produced now for hopefully coming to September board. The areas that we are spending a bit more time on is staff communication. I still think there's lots more we can do on that. I don't think you can ever do enough, but I think we are looking in terms of what's the various ways we can improve on the staff comms in particular. But as you can see, we generally, trying to keep as innovative and as modern. We've now got TikTok as well as Instagram and Facebook, for those of you who, be familiar with that. But as well as trying to make sure we keep some of the traditional methods of communication as well, so that we got that wide reach into our communities. So I'm happy to take any questions, or James is on the call if I can't answer them. Thank you. Shelley.
Again, this is a great report, and again, the way it's been put together is, it's good to read. I just one query, which perhaps James can answer. Under the press and media section, it's on page 429 of the pack. It's just you've got press inquiries were 426 and press releases were 61. I would have, just from my looking at the Twitter and other things, I would have thought there would have been a lot more press releases, and I just wondered if there was, because you're obviously pushing information out all the time and what's going on. So I was just surprised that it was lower than I would have expected. Bear in mind you've got a big presence. So I don't know, perhaps is there a different definition of a press release from, I know, Twitter or whatever? But
yeah, happy to answer that, Shelley. Thanks for the question. Yes, you are right in that it's not everything that we issue proactively. The press releases refer to the formal written pieces that we send to the traditional media. So it doesn't include things like proactive social media posts or website articles. It is purely those things that are sent to the traditional media.
Thank you. Any further comments? Paul?
I just say I think this report is to be commended. I think this is superb work undertaken by the communications and engagement team. I think if you look at 427 and 634, you can see the amount of work and your comparator with regard to Aneurin Bevan compared to the other health boards, which I think evidences the real sort of superb work being undertaken by a sort of small team of staff that get out and about and actually are using digital and social media and all sorts. And I think it's just a very good news story.
Thank you.
And well done to all involved.
Yes. David.
Just to follow up on that and say, I've watched a couple of engagements on Facebook and various other social media presences, and the team do a really good job of debunking myths and being open and honest with people. And I think it's really good to see an organisation doing that, because a lot of places don't. So it's very good to see.
Thank you, David. So well commended. Yeah, thank you to Karen and the team. Thanks, James. Thank you. Thanks, James. Thanks, James. On to a not so crappy report. The winter plan evaluation.
Okay, thank you, Chair. So this paper is presented for noting today, and walking colleagues through the findings from the evaluation of the winter plan. So again, just to remind colleagues of the approach that was taken. So it was agreed that it would be an integrated plan, so heavily working with partners and featuring those commitments. It was based on modelling and insight. So in terms of predictions around COVID, flu, RSV, and also staff sickness. So the plan was framed around responding to that intelligence. And it was framed around 4 key areas. So health protection, keeping people well at home, additional capacity, and getting people home. So that's just to remind us of the approach that we took and how we framed it. So what happened in terms of the forecasting forecasted. Actually, the demand that was predicted did materialise. It did materialise slightly earlier than forecast, but in terms of the numbers and sort of intensity, it was largely in line. The shape of the graphs were the same, but maybe just a bit pulled forward in the year. Both in terms of those demands on those illnesses, but also in terms of demands into ED and where our peak in occupancy was. So our modelling sort of bore fruit really in terms of that it was more or less accurate. In terms of our plans, and I think it's fair to say it's a bit of a mixed picture, and just to update colleagues, the bits of this report that's relevant to the RPB went through that meeting earlier this week. So hopefully you'll see the report is very sort of honest in terms of what worked and what didn't. So it's quite detailed, but I just want to pick out a few under each of those 4 headings. So from a health protection perspective, really good progress in terms of COVID booster uptake, despite best efforts, not where we wanted to be in terms of childhood flu vaccinations. There's definitely some learning we need to take forward there. So whilst we did perform well against other health boards, where we aspired to be. Adult flu vaccination in terms of the older adult population over 65, again, we performed very well there. But in terms of staff vaccination, that seems to be staff flu vaccination, that is going sort of down year on year. So I don't, there's probably something we need to make some assumptions about why that is, but I think it's probably something we need to get underneath to understand what's changed in terms of take up of that flu vaccination. So a bit of a mixed picture in terms of that first sort of domain of our plan. So with some good progress, but a real emphasis on in terms of our collaboration and our engagement with NCNs in particular in delivering a lot of that activity. In terms of keeping people well at home and our aspiration to not suck people into the hospital system, but to, if they do touch our front doors, to assess and decide and discharge quickly. This heavily features the SDEC model, which we've received updates on before. So you'll see the impact that's had in that rapid assessment and turnaround of our patients. Also under this domain is the work we've done around the AHPs at the front door, which we sort of boosted over winter in terms of expanding that from GUH into other areas as well. And again, based on some of this work, we intend to roll that out and scale that up even further. We did have some increase in primary care activity and capacity. And also some reflections in terms of initiatives we put in place around APPs in our flow centre. Didn't have the impact we wished for in terms of better managing conveyance. The hypothesis being that having an advanced paramedic in the flow centre, they'd be able to advise on-scene paramedics and suggest alternative pathways, but we saw no benefit from that investment. So again, a bit of a mixed bag there, and we were unable to mobilise some of our plans around increasing CRT capacity due to some of the recruitment challenges that we had. So no full realisation of the plans under that section as well. And then in terms of additional capacity, this focused in a number of areas. In terms of social care capacity, this is where our response to the 1,000 beds campaign and challenge came in. I think it's recognised that despite our planning, this was very poorly utilised, if that's the right word, low utilisation of the capacity put in place, with themes around the criteria for access and whether we were focusing capacity around sort of 3 to 4 sort of handling per day, but whereas actually the need in hospital was slightly different. Challenges around residency and where patients were going and application of policy. So there is loads to unpick and loads for us to learn in this space that's being taken forward through the discharge board. But despite some sort of disappointing in that area, we did have Cafili's project around new directions, and the Dom Care project was successful in terms of that capacity. There's learning from our homeward bound units that we put in place to tried to provide quite a very innovative solution in terms of how to manage those on delayed pathways of care. But due to it's our inability to fully realise that in terms of access to places for activities of daily living, to social spaces, to really fully implement that model. There were challenges in fully realising that, and the capacity, I think it's fair to say, was used more as additional capacity rather than really moving forward in the new model. So again, very sort of mixed experiences there. And in terms of getting people home from hospital, this focused on the availability of equipment to support people to be discharged, and a significant sort of investment and activity in that space. And I think the last sort of table on that section, sort of numbered here, but on section 4, is around the numbers of patients on the delayed discharge, on the delayed pathways of care. And generally they've, some ups and downs, but didn't materially increase. So I think it's difficult to say, isn't it, that but for these interventions, even though they might not fully realise how worse could it have been, I think is some of that we'll never know in terms of our assessment. But we absolutely know that there was mixed success in the application of those initiatives. I think we ourselves and with our partners have been quite honest in what's worked and what hasn't worked. And we'll take that learning forward into the planning for this winter coming, and already operational teams have started to look at this and had a session. I think it was earlier this week or late last week. So there's a summary of some of the key themes around learning on the last page in terms of the approaches, in terms of keeping it broad from health protection through to capacity. The same day emergency care really features as something that's been successful. Our ability to recruit has been a theme in all areas, but I've highlighted some of those in particular. And that market stability in social care, which really impacted on our delivery and our ambitions for that step closer to home. So I will pause there, and happy, along with other colleagues, to take any questions on the report.
Thank you very much, Hannah. It's a very clear report, and I'm glad to see that we have been honest about what did and did not work. We can't take the next step without knowing that. Are there any questions on this report? Tracy?
More of a comment than a question, I suppose, and it's around the vaccinations. I think there has been good progress, but there is definitely an over-reliance coming forward around mass vaccination centres. I suppose it's a question of sustainability. Doing a vaccination through the vaccination centres is 3 times the cost of doing it through primary care. It's also about where the money sits within the system. Primary care have obviously got a pot of money under the QAF for delivery of vaccinations, which isn't being drawn on. So the number of vaccinations being done through that route isn't where we would want it to be, purely because primary care is overwhelmed with other business at the moment. So it's about how that system is, but the mass vaccination structure, although it's doing a lot of outreach and it's doing a lot of targeted work, which is hugely beneficial, it isn't sustainable from a cost-effective point of view. And I think there's also the challenge around some of the data is good when we compare ourselves to other health boards, but is it good, or are we just the least bad?
Yes.
We have got a situation where we've got an 8-week wait in some places across the patch for MMR. And the challenge that we've got, there's deep dives going on across the wider UK footprint in terms of we're seeing really high prevalence of measles, and we're in a situation where we are exposed to that because of that delayed uptake or reduced uptake, only 1 dose instead of 2, and because of accessibility and reach of vaccination programmes generally. So I think there is a deeper review that needs to be done. We're in a fortunate place this year that we have got additional funding from Welsh Government around health protection, which is tying off some of this. Like I say, it just isn't sustainable financially. And actually, is it ethical that we've got this double running of services against the public purse, where we need to put, I don't know, a conversation into primary care about how we can support them to get these services back up and running, rather than having these specialist expensive services created on the side, which creates an inequality of access, it creates a massive inequity. So there's just a challenge, I think, in terms of how we review that and really identify what is good and what possibly isn't good, but it is good compared to others. And so it's about where we want our standards to be, I suppose.
Thank you, Tracy. I think that was very helpful indeed. And I know Hannah will take that forward with the planning, because we don't want to double run anything. And I can't understand why on earth we've done that. Shelley and then Phil.
Yeah, just well, thank you very much for the report. Just under the section, you mentioned that some parts of the plan there weren't. It's under the home, keeping people at home, but some parts of the things that you put in place just didn't materialise staffing, for example, in the CRT teams. But did we go on, because it says later on, TRT teams and expansion of physiotherapy and occupational therapy delivered. Go on then, but implementation was still pursued with. Was it pursued just in pharmacy and ED? Or were those things? All I'm saying to you is, although you didn't realise it within the timescales, how's the investment been in those areas to put in those improvements?
Only in those areas that not to the timescales, as you said. So we didn't get the benefit over the winter period where we wanted it, but then we did have we were successful in those areas. But the recognising this was a winter plan, we've just targeted the action at those to try and meet those peaks. So we haven't just carried on with all of this stuff sort of regardless. It's been focused on the winter period.
So there aren't additional, for example, physiotherapy and occupational therapy. You didn't put that in subsequently. Do you know what I'm saying? Because I mean, is it there now? So are we at a hang on going forward?
So since February, we've had sort of front door therapy sort of input. The pharmacy ED commenced, even though we approved it some time ago, because of recruitment in pharmacy is just starting now, in fact. So things that we've identified will have an impact for us. We've continued to pursue, even though we didn't deliver them for winter. I think what is incumbent on us, given the paucity of workforce and the financial pressures that exist, is that we absolutely must for this winter maximise bang for buck. So I think we have to definitely revisit, I guess, decisions we've made in terms of the prioritisation of resource, both staff and workforce, so that it delivers maximum impact for us. Now, my personal view is probably therapy and pharmacy at the front door is probably not what we would deprioritise, but we have to give that same level of scrutiny throughout, really, maximising that. But those things are in place now.
And that funding is through the RPV? Or is it part funded by the RPV?
Yeah,
like
that's
the therapy. Yeah.
Oh, yeah.
Well, some of the therapy money came through Welsh Government.
Yes, the therapy money is,
yeah.
I think
it's a special grant from Welsh Government.
I think, sorry, my point I suppose I'm trying to make is that we've got these things in place and they are improving the service, albeit they didn't necessarily improve it for the winter plan, but we would want to keep these on. So my concern is that are we funding those ourselves if they don't form part of a priority for the winter plan next year? Does that make sense?
Can you answer that, please?
Yeah, I think we learnt a lot from the winter in terms of the therapy input in particular. I think one of the things we know about therapies, whatever you are, if you're physio or OT, you're not attracted to a fixed term post. They want recurring. You know, where we have recurring money and we can put a permanent contracting post, they're queuing up to work with us, and it's really challenging to recruit OTs and physios to fixed term posts, which is I think what we're trying to do here. Whereas with the front door therapy team, we took a different approach. We did have recurring monies, that's from Welsh Government, and we could make permanent appointments, and we had no trouble filling those posts. And we're going to learn from that. We're going to learn from that's how we get the boots on the ground, is getting those permanent posts. But actually, the front door therapy team has been so successful, we are absolutely carrying that on, and all being well, we'll now expand that as well. So it's not just a winter scheme, it's something that we've learned works all the time. And something that the ED team actually really welcomed, because it's that extra layer of support that they've got then in terms of they're a community team, they're not a hospital team, they are experienced community therapists who know about community services, they know how to keep people well at home, and they can, when people do find their way to hospital, they know how to do the right things and get them back home. So it's proved really, really effective, and it's absolutely some learning to extract from the winter plan, which will feed into what the plan looks like for the next winter.
Do you want to add to that?
Yeah, just to add, so Shelley, in terms of the learning from the winter plan, some of those schemes will have continued, some of them will have paused. One of the things we've done in the 6 Goals board is to just do a bit of a stock take of everything we've got, because whilst the therapies at the front door is great, it does cut across our Home First service, for example. So actually you've got 2 things delivering the same outcome, and sometimes we're double counting. So there's something about being really, really clear in the evaluation about what is delivering which impact, how that's funded, and therefore how we demonstrate the services we need to redesign in the way we need to. So, for example, the CRT developments, those are continuing, but that will be in the space of the new 6 Goals programme, which will really focus on admission avoidance. So it's about right-sizing our services to get that care closer to home. But I think with a lens of, we've really got to be rigorous and evaluate, as Leanne said, what works, what doesn't. If it doesn't work, we stop it. If it does work, you know, in part, how can we make it even better?
Thank you. Sorry, do you mind if I just add to it? Because I think it's really important. And some of that is about simplifying the pathways rather than confusing with yet another service that does something, you know, because I think that will improve the success of referrals and appropriately match workforce to patient demand and sort of requirement, because, you know, often we can't describe some of those systems, but sorry.
Bill?
Yeah, thanks, Chair. Well, clearly some things worked, some things didn't. I mean, one of the things that didn't work big style was the purchase of the community beds. I mean, we talk about being honest in the evaluation. I don't think we've been terribly honest, really, because there was no hardship sign-up across the board to that initiative before we embarked upon it. I mean, I'm trying to chair several meetings where there was great resistance to that initiative from local authorities. I mean, we just about managed to push it over the line to do it. And I think therein lies the problem, really, is if you don't have total sign-up, whole system sign-up, then things are not going to work. And there wasn't whole system sign-up to that. The analysis talks about the criteria was wrong. Well, we could easily change the criteria because we set it. That wasn't set externally. We decided what the criteria was. So if that criteria was wrong, we could have said, well, let's modify that then so that it's going to be more in line with what we need. But when we think that we'd actually purchased community capacity, spent money, and then we had people lying in hospital beds who shouldn't be there, and we had community capacity that we spent money on and didn't use, I think we need a bit more honesty around this issue. I mean, if we're saying that it's off the agenda for next year to be looking at whether we purchase extra beds in the community, then I wonder what our solution might be, other than what we really did this year, if we're honest about it, was create a lot more beds in our hospitals. Because that's what we did, didn't we? The reason why we survived winter was because we created lots of extra beds. Now, I don't know how many beds we did buy in the community, but they were fairly significant. And that, had we used them, it would have eased the pressure enormously on what was going on in the hospitals. So I think we need a bit of pushback, really, to our partners around this before we just go along with the idea, well, it didn't work. It didn't work for perhaps some of the reasons that I've just outlined. And if we're not going to do it in future, then we need a pretty big step change in what we do in other provision, because we're not seeing that step change at the minute. And I think that we are rolling into next winter with some of the initiatives maybe that we can't even now think about. And I think by default, we will be forced into, again, putting people in any available space in any hospital that we have. I think that's where we will be. I know this sounds pretty downbeat, but I think that's where we are. And I guess these are the kind of things we need out on the table when we're having discussions with partners, that we really do need to get more real about this, because I can't recall what we actually spent on the provision, but I mean, it was a tremendous abuse of public money in one respect because we paid it and didn't use it, didn't we? So, I mean, a lot of our meeting today is about money, and we've a pile of money there that we didn't even use. So I think we need to hold on to this one really and really try to hammer this out.
Yeah, I don't disagree with that. And yeah, in terms of, I mentioned the word honesty in there, didn't they? But there's, I think through the winter planning work we're doing now in terms of preparation for the next season, we absolutely need to take this to that next level then in terms of reflecting on what will we do, not just in terms of what we do, but how we approach your point you made about the engagement with, and so it's about how we develop it as well as what we do, and using the new 6 goals programme, the framing of that is going to be key rather than setting up lots of parallel ways to explore that.
Yeah, I mean, I'm sure there's lots of great work going on with 6 goals and all the rest of it, but it's the pace of it. It's just that these things just seem to take so long. I don't know how we inject pace in it. That's the issue. And I mean, Anne will talk later probably today about the Regional Advisory Board, and I mean, it's like walking through cement that's almost gone solid, you know.
I think one of the things that we've been doing in the Discharge Improvement Board is trying to have those conversations. I have to say, it is tough to have those conversations about pace and change. We already commission a number of beds outside of those beds, which we aren't using effectively collectively. We have extra capacity going into community teams that we're struggling to utilise, and I think we do need the difficult conversations through the RPB structures to say, actually, you know, this isn't all of our benefits and our citizens, and we need to make sure that we're using the capacity in a simple way, as Leanne says, in the best way possible. So any support, Phil, would be greatly appreciated.
Thank you. And I guess there are 2 points, but the first one is actually along the same kind of lines as Phil. You know, we've plainly got stuff that hasn't worked as well as it should have done, and this plan usually comes quite late. And then if people around the table are saying, well, you know, we think we'd like to change this, it's very often too late to change it. We're already in July. We're getting an evaluation of last year's winter plan. I guess my plea would be to how do we get the pace into it? How do we shift it so that we're actually looking at a winter plan in the autumn rather than by the time we're already into the winter, and we look at getting an evaluation earlier in the year so that we get the opportunity to explore more possibilities, because the challenge is that if we leave it too late, then we will, as Phil says, just be scrabbling around for beds, because we're not allowing ourselves the space to have the conversations that we need to have. So that would be my first kind of reflection on what's gone well, what hasn't, and how quickly we get to all of this. And the other one is around staff vaccination, which has been an ongoing thing for as long as I can remember. And the question of why pops up, you know, do we know why the staff aren't getting vaccinated? Is it because, for example, they don't want to take time out of their busy day to head off somewhere to some mass vaccination centre, or, you know, I don't know what the answer is to that. So I think a piece of evaluation on the why that number isn't shifting would be really helpful, because we know, don't we, that staff sickness in the winter is a challenge for us, and also there's whether or not people who are in our employ, who we should be looking after, are picking up things in hospital that they're then taking home to their families as well. So that, I think, is a key message, that we are not really understanding why it's not working at the moment.
Thank you. Tracy.
Just to come back on the staff flu piece, Pippa, you're absolutely right. So we've done a review of that, and we are changing the practices around the way staff flu is going to be delivered this year. So I've moved it within the team, and it was sitting in completely the wrong part of the team. And I don't think there have been enough conversations with other divisions in terms of how they want to receive staff flu and what works for them. I don't think that question's ever been asked. So I hope that this year there will be a radical difference on that. Because like you say, as a health service, to have less than 50% uptake, I mean, that puts us a long way from herd immunity. And given the fact that our vulnerability becomes our patients' vulnerability, and that is a thing that we need to bottom out very quickly. So I'm hoping that what we put in this year, working more closely with the divisions on how that's delivered, will make a significant change on that.
Good. We do need to. Leanne?
Just to pick up on Pippa's point around pace, so I think sort of you're absolutely right. I think last winter was, you know, even for those people that have been around for a long time, I think was credited as the worst they'd ever experienced, you know, across the system. And we can't afford to go into the winter sort of in an unplanned way with plans that are not going to deliver anything or I guess not meet sort of or deliver the impact that is required for our population. So and it is a real shame that some of those schemes didn't work. So just from an operational delivery perspective, it is health focused at the minute, recognising we need to take that into the and liaise and link in with sort of the partnership sort of guys. We've met as an operational team about that step change so that we do go into the winter prepared and dealing with what's within our gift and coming up with plans that are deliverable. But I think just a heads up, and you will be very well aware of this, we have neither the workforce nor the money, nor the financial forecast coverage within our financial plan for sort of a winter. So it's a pretty difficult position to be in, which is why I think sort of those early discussions with the operational teams about what is the art of the possible and thinking creatively about how we stay safe during winter, I think is really, really key. But just to say that those conversations have already started and need to continue to be progressed at pace now so that we can deliver something safely.
Well, the report will go to the RPB anyway in September on what we do. Just to add to that, I think we picked it up in an earlier comment where you know, so there isn't a load of extra money to go into a winter plan, but there is already a lot of investment in this space, in core and in. We talked to the RPB about, you know, the frailty work that I know is aligning now into the 6 goals, but the AHP model. So there are resources. So it's about how we make sure we sort of simplify, don't duplicate, and as Jan's expression, bang for buck in terms of where we target that resource to schemes we know work. Any further questions?
That's got the RPB and the format of the report as to, I mean, obviously the report comes to this board in a particular form. Is there any things in addition that one needs to provide in terms of reporting to the RPB? I mean, I would think they're probably quite keen on information about their own localities. I mean, so is that sort of a...
no, the report with much of this content went to the RPB. What time is it?
It was only
yesterday. Oh, the day before. It was Monday. Apologies. Yeah. So the same level of information. It was there'd been a workshop to sort of inform it, and some of those joint sessions. So it's similar, you know. Same content. If you looked at the RPB papers, you'd recognise the language.
Is it locality?
No,
oriented?
no, it's a partnership. Yeah, it's not split into 5 areas.
Okay.
Okay, thank you. Might I suggest we have lunch? We reconvene at 1:25. For proof of concept and service evaluation at YYX. Jenny.
So if I just preface this and briefly, Linda and Tanya are here as well.
Yeah.
So board requested some time ago a review of enhanced care. Having spoken to the team and to Rob, doing more of the same wasn't going to be the right thing to do. We know that some of the enhanced care response that we currently have in place, for example, agency healthcare support workers or bank healthcare support workers, actually doesn't deliver up what the patient needs, because you'll tend to have somebody who doesn't know the patient, perhaps not familiar with the environment, and who isn't perhaps focused on providing a level of care that would respond to the patient and the way in which they're behaving, rather than just providing, you know, that sort of one-to-one observation and stopping them falling. We know sometimes, particularly with patients with dementia, you're better to let them wander. But again, there's that fear of what does that mean? So Linda and Tanya have done a brilliant piece of work focusing on what if we had a different model that was based around what the patients need in this space of enhanced care. Are there opportunities for it to look to test whether we could use what we're currently spending in variable pay to enhance our wards and to enhance our team around the patient in a way that delivers care differently and meets their needs from a holistic perspective, not just a medical or nursing care. So that's the basis of the concept. We want to test it, but as over the next few months, you might hear me talk a lot around team around the patient, because I think old style ways of looking at how you provide nursing care are perhaps moving forward into we need to provide a skill mix that responds to the care needs of the population we're dealing with, rather than you need 5 trained nurses and 4 healthcare support workers. So this is a different concept completely. Linda?
Yeah, thank you, Chair, thank you, Jenny. So just to enlarge on what Jenny's already said, I'll keep this brief because I'm assuming everyone's had an opportunity to read the paper, but as well as board wishing for a review of our enhanced care, I think as nursing, we really were keen to consider and better understand how we're providing enhanced care. You know, we're very conscious we do not always get this right, and we don't provide the best model of care for these patients, and it's often a very restrictive approach which can further compound the problems with enhanced care requirements. It can cause deconditioning, it can actually increase length of stay, and it can potentially mean a patient doesn't return to their own home. So we really need to consider how we upskill and develop new roles to be confident and engage with these patients. And we're also looking at how we enhance our use of technology in this field. So you'll see from the paper that we are using there's a significant cost associated with delivering enhanced care, and the majority of this sits within the division of medicine. And unfortunately, the same division, as you'll see, is the highest instance of falls, of which YYF is of significant concern. So just in summary, in agreement with the division, the test of change will be run at YYF. The paper articulates what will look like. At this point, there is no ask financially, as we really need to determine initially what is there currently, what will make the biggest difference, and what is required, and whether that's new roles or digital solutions or a combination of both. So just massive thank you to Tanya and our team for developing the proof of concept, and more than happy to take any questions between us.
Questions?
Yes, I was just asking a question. So I'll ask it anyway. I was wondering whether the agreement that we've reached this morning in terms of stroke rehabilitation will interfere with the implementation and evaluation of this scheme, as it's all at YYF.
It shouldn't do, because there will be, Linda, Linda, you're aware of the stroke reconfiguration and reconfiguration of coated beds. Yeah. We still have medical beds at YYF. It would be, we will still pilot there.
Okay.
I have had the discussion with the division as well as to whether we still feel that would be appropriate, and they most definitely feel it'd still be appropriate. And many of our, even with stroke patients, very often they require an enhanced level of care. So it's felt that would be very beneficial.
Okay, thank you. Questions then? Any questions? Shelley?
Can I prefix what I'm going to say? Right, I understand this, and I do agree that we need to have a review completely of how you're dealing with enhanced care, but I wasn't sure about the financial aspects of it. Linda's just said it's obviously there's no financial ask at the moment, when you look at this section on the financial assessment, investors say there isn't any financial information in that. So I'm not quite sure what that covers. But also it talks about, in another part, it does mention that you'll use currently, obviously some of this is being paid by variable pay. So we'll be using part of that to fund some of this. This is how I've interpreted it. But my understanding is the variable pay is actually over and above the budgeted pay in any event. So actually, this is going to continue to cost us at the moment until perhaps, you know, the effectiveness of the service or the changes are made. So I just want to be clear that there is a cost, it's an ongoing cost. And so what I'm saying to you is this isn't funded in terms of that additional cost at the moment. We're trying to reduce variable pay, not maintain it at the continued levels.
And did you want to respond?
Yeah, I think what you're saying is correct, but we would most definitely expect to see two things. We would expect to see a reduction in variable pay as a consequence, and we would expect to have in place substantive staffing to deliver these roles and improve the patient experience. So appreciating that it may not eradicate bank and agency, but we certainly see a reduction and hopefully flip some of that spend into substantive staffing that will meet our patients' needs. If there was a request for funding, I think we'd probably have to go through the PIP process in order to secure that, but we certainly would hope to see a reduction in financing. We specifically didn't put finance in because at this moment in time we just do not know what it's going to look like, and until we do the proof of concept we won't understand fully what is required in order to deliver this model. But hopefully we'll bring that back fairly quickly. In the appendix, I think it quickly lays out how we'll progress with the proof of concept, and we'll make sure that's fed back into the exec's next steps.
But Linda, to be very clear, we will not be worsening the medicine division's financial position. This will be utilising and taking away some of what they're spending currently on bank and agency, putting it into a different spend in a small area to test whether this delivers financial benefit, service benefit, patient benefit. Thank you.
Next, just to add to Shelley's point, in terms of the way that we've done the budget setting this year, we've tried to recognise levels of expenditure previously. So, and then we've looked at where the savings opportunities are as part of this piece around trying to improve accountability. So some of these areas might have a level of funding to support variable pay, albeit there'll be quite a kind of savings assumption on that. So it's slightly different to perhaps what we've had before. So hopefully it will give that opportunity and incentive for the division to do that. Thank you.
On your comment that this is not a rigid application of a formula, but actually much better designed to serve the needs of the individual. How will that clash with the Nurse Staffing Act requirements?
So I might let Linda comment. However, what I would say is that I think there is a groundswell of opinion that whilst the Nurse Staffing Act is important in terms of recognising trained nurse levels, there does need to be some flexibility around the needs of individuals.
I would agree with that. I don't think you need to say any more.
I was just going to say I've been asked to provide evidence to the committee in October to that effect. So actually this is really important for us from a number of perspectives around proving our concept that actually this needs to be about what patients' needs are, not an arbitrary figure, despite a level of protection. But Linda, is there anything you wanted to add?
No, not really. And I think, you know, at the end of the day, the Nurse Staffing Act, it should be about about professional judgment. I would also hope with the implementation of the proof of concept, we will see patients' acuity be reduced because we'll be looking after them appropriately, as opposed to a potential of it's almost like we're restraining these individuals. So I would hope to see a reduction in acuity. And I just would really like to emphasise the Nurse Staffing Act is about professional judgment, and it shouldn't just be about numbers of RNs and healthcare support workers. I'll leave it at that.
There's just one other thing I'd want to add, and that is around patient harm. Now, we've never quantified patient harm, as far as I'm aware, in the board, in terms of the impact of serious incidents, serious falls, inquests, but I think we need to start to, because actually we may need to hold our nerve, because this concept might increase falls, but we'd expect to see harm go down, because we'll be allowing individuals to mobilise and to walk around and to do different activities, but we'd expect harm. So it's important we monitor harm, because we all know harm costs. It costs the individual, it costs their family, it costs us. So it's important we focus on the harm.
I just think that's something that very naturally falls under the remit of PQSO committee. I know in our last committee meeting it was something that we discussed in terms of falls, whether or not they were falls that caused injury or whether they were as a result of greater mobilisation, and that is something that that I think, Peter, you're going to bring something back to the committee, aren't you?
Yeah, absolutely. So, you know, we fortunately, the falls we have in our hospitals that cause harm are a very small minority of falls. That's good news. But what we want to do is really avoid any kind of harm, really. And that's hopefully what this will do. I do believe it will reduce length of stay. We can get people up and moving and be more active. What we don't want to do is constrain them to their bed. That won't get them home. It's not good for good experience anyway. So feels like the right thing to do.
Yes, but I'm really looking forward to seeing what the results of this are, and I was really glad to see the kind of time frame actually set out as well. So thank you for that. Save me asking.
Martin.
Yeah, I think that issue of harm is a really interesting one, because I was quite glad what you said there, Peter, as well, in the sense of the harm of not doing something, as we learned with vaccinations, for example, is as damaging as the harm of doing something. So, I mean, you might increase falls, but if you increase mobility, you'll probably increase blood flow, which will then help in terms of other areas, but also will enable someone to be independent quicker and then get home quicker, which is a benefit for them and for, obviously, the hospital as well. So it is balancing those risks, isn't it? You can focus on one area of falls and then you forget the risk elsewhere.
Yeah, so completely supportive of this. I just wanted to kind of and keeping those correlations between harm, but you know what is quite stark in the document is the reduction in the number of hours that we've used for enhanced care. Just take this April and May to last April and May, where we were spending £1 million a month on enhanced care. We're now at £500,000 a month, making sure there's no correlation between any incidents, but what it does also show is the hours worked is reduced but not as much as the cost, because we have done that shift from our own staff and bank staff from agency, which again will improve the quality of the care that we provided. But you know, I think it does reflect the efforts of the teams in terms of making sure we absolutely are using enhanced care where appropriate, but important to keep that kind of link into incidents and harm, as Jenny said.
Thank you. I take it then that we are all happy to endorse the proposal for the proof of concept in YYF, and then we look forward to seeing what the evaluation has to reveal for us.
Thank you. Thanks to Tanya.
Thank you.
Thank you. Bye. Wikis update then, Paul.
Yes, thank you, Chair.
This is one of our favourite topics here. Carry on.
Yes. Thank you. This paper then provides an update on the implementation of the Welsh Community Care Information System across the Health Board. This system was procured nationally to support the digital transformation of community mental health, therapy and social care services. The system went live into mental health and learning disabilities in August 2022 and is now operational in 120 teams covering 2,000 staff across the Health Board. Several issues have been encountered during the implementation, and there's been complications associated with data migration from our legacy system. These issues have also resulted in the service operating without a digital system for a whole week,
which also then caused a large backlog of data entry, which was a real challenge to the service. These issues also meant the Health Board was unable to meet its statutory reporting commitments from a mental health perspective. So in order to address these issues, urgent change requests, 9 in total, were logged by the programme team nationally. These have been deployed in May 2023, with improved reporting now expected in July 2023. Although further changes are required to support some local reporting requirements. I've had an update this morning from the team and we're still confident that the reporting will be reinstigated this month. Other specific issues that have been encountered with the implementation is poor system performance and reliability. Again, this has improved recently and the team are reporting call volumes are now reducing. The legacy application used by the Mental Health Service has been unsupported since 2019 and work is still ongoing to migrate some remaining data and to ensure good data quality. Some of the full benefits that were outlined in the WCCIS business case have not been realised due to integration challenges, and the mobile application is still not available from the supplier, although this is being piloted currently in Howlback. There have been quite a number of resource challenges within the team to support the ongoing data entry I've already mentioned, quite a large training need requirement, change requests, and obviously the fault and issue resolutions that we've been receiving. And as mentioned, benefits realisation work really has been delayed because of this. There's also a wider concern that the current platform for WCCIS reaches end of life in January 2026, and a strategic review of the future of the programme across NHS Wales has been presented to Welsh Government ministers for a decision. When announced, we will obviously then need to take that on board and review with a wider Gwent region to determine our next steps. Despite this, the team have adopted an action plan really to focus on benefits for the next period. So whilst we wait for this strategic review, we need to do something tactically to try and improve the current situation. So we're reviewing the support services and transition into business as usual to making sure those processes and procedures are in place to support the service. We're mapping available functionality to service requirements, making sure that we're prioritising the outstanding work and really pushing the supplier and DHCW to deliver that. Development of that functionality roadmap with the supplier, and then commence planning for further phases in the implementation programme focusing on community nursing. And of course, we need to review the outputs of that Welsh Government strategic review. Just for one item that wasn't in the paper, a report on WCCIS has been issued this month following scrutiny at the Health and Social Care Committee and the Public Accounts Committee within the Senedd, and they've made a number of recommendations to Welsh Government and Digital Health and Care Wales, which we'll closely track as well.
That'll be interesting. Have you seen it?
I have had a quick look at it, yeah.
Is it synonymous with what we've found?
It is, yeah. There's common problems across NHS Wales, yeah.
Thank you, Paul. Are there any questions, Paul, and then David?
I just noted it said on there was a lack of a national delivery plan. I would have thought that within this particular system, that's the first thing to be considering when we have a national delivery plan, because it says on page 475, I think it is, and the wording 473 then. So, any observations on that? Are they going to put in a delivery plan? It's on 474, top of 474. So the inability to deliver these functions due to the lack of a national delivery plan have impacted significantly the ability to deliver and realise the benefits.
Yeah, I think so. What we'll be working on with DHCW and the supplier now is a real key delivery plan for themselves, because the national delivery plan was also often focused on delivering the national infrastructure associated with WCCS, because they could say it was then ready for deployment, but then kind of the local delivery plan is down to local organisations. But I think what we want to do now is work with the supplier and DHCW to make sure that they can deliver what we require.
Right.
So there is a misalignment there that needs to be addressed.
All right, and that's currently being worked on. And
it is, yeah.
Okay, thank you. That's helpful. Thanks very much.
David.
So obviously this one's one of my favourite topics. I'm sure that Hannah and Chris previously fed up with me asking the same questions and talking about this one. It's been live for a year now, and we are still not getting what we expected out of it. In terms of benefit realisation, the harm caused to staff in terms of problems with it not supporting what staff need, the backlog of paperwork that we have not been able to move into it, the lack of reporting, which I think has led to a couple of letters to us in terms of breaching our statutory requirements and others. So it's really disappointing that this national service or national programme has not been able to deliver what we want. I'm glad we've got a plan for going forward. I am just nervous that we continue to put a significant amount of energy and effort into making this work, and it's unclear if we're ever going to get what we expect out of it and whether the effort we put into it actually leads to the benefits that we need. So given there has been a decision made at a national level on what happens following the end of life, we haven't seen that. I haven't seen it either. I didn't realise the decision had been made, even though I met with DHEW last week.
It hasn't been made. It's with Welsh Government ministers for a decision, so they've had the option.
So DHEW told me last week that they hadn't reached a decision, let alone it going to the ministers. So it's an interesting position there, but I'm concerned that we continue to put effort into this and we don't get what we want out of it. So I think the question I want to ask is, do we have an understanding of the financial impact of the delays and the issues we've had? We've had to have staff look after this much more closely. We've built up the backlog. We've had to support more problems with it and so on. What's the financial impact of that extra resourcing that we've had to put into it? What's the impact of delays to the benefits that we were expecting in terms of the business case? That's all going to have ultimately a financial bottom line, but a staff and patient issue as well that we need to be aware of. We need to quantify somehow. But also, what are the real impacts that we've made to staff? So have we spent any time with staff to understand how they're feeling following the rollout of this? What problems have we actually caused for staff? Do we have anything that we can bring back to the board to show us the impact of the problems this system has had? Because I think it's really important that we not only celebrate successes when we actually deliver something works well, but we really clear and highlight the problems that staff face when systems like this go wrong. And we quite often need to talk to DHEW and be very honest with DHEW and with the supplier and with Welsh ministers and the chair of DHEW and others to say, this is the actual real harm that this system has caused to staff and to patients. So can we please try and collate some of that information so that we can present back to those at a later date?
Certainly.
Just and Leanne came in because she's met with the division, and specifically we picked it up as part of the mental health divisional review. Whilst there was a lot of focus on the reporting, I think probably whilst some of the programme team have been working with the staff really closely, I think understanding the impact on the operational delivery has been an issue. And I know Leanna's working with the division to bring an SBAR to executive team in the next week or so, which is setting out what we think and understanding the risks both in terms of patients and staff, a bit clearer than perhaps what we've understood until now. So I don't know, Leanna, if you want to add to that. So.
Yeah, I think you're absolutely right, David. That was my point, actually, to come in. So I think just for awareness, I caught up with Janice when I took on the portfolio about the impact of this on the teams and what that means from an operational service delivery perspective for our teams and our patients. So we're still getting 700 calls a month is what Janice reported to me. Paul, I don't know if that's changed at all, but I think until that reduces, we're nowhere close to delivering anything close to what I would accept as business as usual. We've got examples. I know we were in the in sort of extremis when we had some IT issues. 20 minutes to load one page. We've got clinical teams sat in front of computers. We talk about efficiency, impact, and Jenny and I sort of in a conversation we'll have later on in terms of an update on mental health. It comes up frequently. That the impact that is having on their clinical service delivery and the tone that will set for them. People giving up on their admin sessions because they can't access the system either in terms of the speed of the system. It's simply not, you know, George has come talking about sort of impact on staff. You can't underestimate the working environment that and the impact this has on staff. Is definitely, I think the mental health platform we've got allows us to have that conversation with teams, but I do think we need to look seriously at alternatives and try to do whatever we can to make this easier for us.
So I'd like to encourage, like we've seen a video this morning, the patient story video, that's really powerful and helpful. I'd like us to think about doing something similar for the issues that WICIS and so on has caused for staff. I think something like that is powerful like that we can present back to Welsh ministers, we can present back to DHEW to explain the harm this system is causing to our ability to deliver, I think is really important, and we need to do something along those lines. We talk about numbers, we talk about stats, and we talk about reporting. They don't resonate. A video or something that shows the real problems will resonate, and that's what we need to do something along that line, or it's never going to get solved. We're a year into this rollout. It's clearly not working. It's not doing what we want. I'm a little concerned that we're going to end up in 2 years' time having to completely replace this again, because the national system is going to be end of life and we're going to have to switch to something new. That's going to put us back to square one again, and we're going to have to do this all again. And I really don't want us to end up in that position. So I think it would be very, very helpful for us to have some powerful evidence to present back to the national programme about what's going on, if only to stop this from ever happening again. On another national system, but also I think we need to look at whether there's an alternative, because I don't think, it doesn't feel like this is working.
Yeah, and the backlog issues, the safety issues that we're experiencing won't be helped by sort of delays, further delays in terms of the speed of the system either. It's one of the psychologists actually shared with us, didn't she, Jen, that she'd actually, it was so slow, she actually videoed the screen. So we've got a video of the video that we could use, but it's
being evidence like that is more powerful than talking about it. So I think it would be helpful if we can collate that together and use that, because it's all well and good the committee, the Senedd committees have writing another report about WICIS. There's been 5 of those. There's been 4 National Audit Office reports on the problems with WICIS. It's come up in multiple coroners' reports about the problems caused by WICIS. None of these seem to be making an impact. So I think we need to do something with the right report.
I'm happy to go out to the service as well, to spend the morning with them, just seeing how they use the system, so I can see it from my own perspective, and I can feed that back to DHEW directors. I don't know if you're aware, there was a clinical usability study recently completed across NHS Wales. So we saw the first results of that yesterday. I think there was over 3,000 submissions from clinical staff. And what that gave us a clear evidence was it wasn't, typically the stats we see is number of calls logged or number of calls closed. But this really showed us what clinicians thought of all the systems across NHS Wales, and we're going to use that to have that conversation with Welsh Government about what's needed to address some of these long-standing issues.
And interestingly, Paul, I don't know where WCCS, if where they featured on there, but CWS was number 2 on the list of the preferred systems, which is our own system that we know we had challenges around integrations. But I think it's that type of evidence is helpful.
Yeah. Can I ask, is it being used in social care? Social care teams using it? Outside mental health, I mean in general. Are they using it in children's services, for example, in local government? Do we know?
in some locations, I believe. So.
It's the core system, isn't it?
Yeah.
There's a bit that I was trying to extract from the report and trying with the services. So we have got all these problems, but you've now got a system that you both can see. So is there benefits that you've already experienced as a result of this, despite, you know, and that's the bit I've not been able to extract, I think, isn't it, in terms of it's become so difficult.
So there's some very good documents and reports that have been done by other parts of Wales where WICIS is in use, and it highlights problems where the biggest issue with WICIS is it's not one system. It's something like 22 different systems. Every local authority has its own instance of it. Every health board has its own instance of it. And sometimes they work together and sometimes they don't. And there's examples from reports where because when services moved, when Cwmtaf and Swansea Bay's regions changed, the WICIS installations didn't. And so you've got a split between the Cwmtaf installation in Vale Glamorgan versus the Cwmtaf installation in the North Fair area. And this is the problem. It's not one system; it's multiple systems. So even if it is available in social care in our local authority regions, that doesn't necessarily mean it works particularly. It connects into our version. Doesn't necessarily mean it can.
No, but is the integration the issue then? Because if it's working for a children's service department, for example, a single agency, there's not much integrated work goes on really. That would require the system to be used in an integrated way. If you introduce it to a mental health team, which is multi-agency, multidisciplinary, then it's trying to deal with different agencies' requirements. Probably they need to integrate in a single system. I
think probably the first ones to use it in mental health. So that's
yeah. I mean, this is. There've been loads of software houses over the last 25 years that tried to do this. None of them have managed to do it. I mean, one of our weaknesses, I guess, with respect, David, is that we keep believing these highly paid IT consultants who tell us that this new system is going to change the world. You know, that's the problem. And of course, they end up that they don't really do that.
Because we too often focus on systems rather than the problem that we're trying to solve.
Yeah. And just as an example, one of the big benefits of this is that integration with CWS and WCCIS. So if a patient presents in hospital, somebody presents in hospital, they'll automatically send a notification to the mental health team to say, so maybe their follow-up that day, you know, will have changed because they understand that's the bit that we are still pushing for integration with DHW. That is where some of our prime benefits come that we can't get yet until we get that integration, and getting a time scale on that plan has been a consistent challenge.
Thank you. I think then this is a cause of great concern to us and has been for some considerable time. And I think that it would be helpful to have a staff story on exactly how difficult this will be. And that we'll take forward the whole issue of risk assessment, because that'll be important as well. Okay, and we'll return to this no doubt. 5.7, the Q1 performance and outcomes report panel.
Thanks. And this, you have a very long, detailed report that you're becoming used to the presentation of. So just I wanted to say a few things about the report before drawing some of the stories out from it. There's an additional chapter now being added because obviously this year we've got the ministerial priorities, those templates we reviewed and updated and those commitments. So a chapter's been put in that takes sort of that slice through our activity and work. So that does mean we've now got quite a lengthy report and recognise there is overlap and duplication between the life course approach, what we're trying to do in the clinical futures programmes, ministerial priorities particularly. So we are committed to making this more, to connecting it more. So and for me, it's really important that what the clinical futures programmes are driving at, as well as the longer term improvement to some of those performance ambitions that we commit to. So we will be doing work to better connect between the various chapters. The other bit that's important to note where we'll continue to develop is the link to the quality outcomes framework that Jenny and her team have been leading, linked to the quality strategy that we signed off recently. So how we present it in a coherent way, we'll be working through. And we do actually have a session with exec team tomorrow to look at some other performance reporting and framework issues. And then the last bit before going into some of the detail, I just want to apologise. There's a bit in the first chapters around the life course where you have the tables that go through priorities and then the performance. The date in the first sort of value column, baseline value, says March 23. That March 23 date is wrong. It's an April last year date, so I will get that corrected and reissued. It just, in the various iterations of this report, that error's popped in, so apologies for that. Otherwise, it's confusing. We've got a few lines with March 23, but different values. So I'm sure some of you picked that up as well. So apologies for that, wasn't picked up in my last read through of it. So that's a bit about what we're trying to do with the report as we continue to improve it. In terms of the detail, there is a lot of detail, and it's probably best if colleagues want to take the questions to where they want to take them. But I wanted to take the opportunity to update on a few areas, recognising that because of the nature of some of our performance ambitions, some of our most recent data is quite old, where some of it takes a while to come through, or we haven't got it for the reasons we've just discussed. But in some of these areas, we now have the June position, and they're in the ministerial priority areas. So I just wanted to draw out updates on that. So in particularly around planned care, recalling that the minister's priorities around targeting the length of wait, both for outpatients and for treatments. So 156 weeks, which is obviously 3 years, which is an inordinate amount of time to wait to access. We already don't have any outpatients waiting that long, and we are on track to deliver our commitment to have no patients waiting for treatment by the end of September. Indeed, most will be gone by the end of August, and we are ahead of our trajectory on that. But by the end of September, we won't have any patients waiting for treatment over 3 years. So that's positive that we're delivering on that commitment. Our June data then tells us as well, in terms of our 104-week waits, we are on track with the 7 specialties, sorry, I should say, with 7 specialties that drive those numbers, you'll remember, in surgical specialties. Of those 7 specialties, we're on track with 5 of them, but we are having some challenges in 2 of them around outpatients. So that's the specialty of ENT and orthopaedics. So we are off our trajectory on those 2. ENT one is we have an improvement plan in place that seeks to incorporate audiologists and some other improvements into that. So expect to see that improve as we go into next quarter. And similarly, orthopaedics is related to this position with the subspecialty of spines, and again improvement plan to remedy the delivery there. So really positive that in many of those specialties we're ahead of trajectory and within the tolerances. Similarly, with our ambition to eliminate all waits of 2 years by the end of the calendar year, so by December for treatments, our pinch point at the moment is around urology. So again, we've got plans in place to try to mitigate and claw that back. In terms of the 52-week wait for outpatients, for the same seven specialties there, 3 of those are off track on the trajectory by the end of Q1, and the same 2 I talked about in terms of 104-week waits, ENT and spines, but also max fax. So we had a good session at the planned care board, and Leanne's team run the assurance meetings with some targeted action about how we can get those back to delivery. It's really important in terms of our credibility on those that we are delivering at Q1. An important point to make in terms of these trajectories is just to remind colleagues that when we approved them, the updates in May, we had assumed that the cataract business case would be funded. Whilst it's not impacting on our performance now, because we hadn't assumed gains from that until later this year, we still don't have a decision. So some of our delivery commitments are at risk if we get the delay continues, or if the decision is not in our favour and that's not supported. So we'll have to rerun some profiles there. Another area I want to highlight is cancer. It's a real priority for us, clearly. And in terms of the single cancer pathway, we've achieved our commitment to hit 60% in Q1. We're just over that, actually, 60.2, and that's the highest in about 11 months, I think it is. So really good progress there. We are slightly off target on the patients waiting over 60, the backlog of that, the over 62 days. And it's really important in terms of when we're trying to rectify that, the commitment of the teams is that the cancer capacity we have, whether it be outpatients or diagnostics or treatment, is primacy really goes to cancer patients. So there's a direct relationship between a cancer pathway and performance and the planned care we just discussed. And then we've talked about the mental health WIC issue, and I was going to draw attention to the ND issue, but we talked about that in the context of the patient story. So lastly, being remiss not to mention the urgent emergency care system. We know the huge pressures that we have there. You'll see from the report that in terms of progress, we are getting an increase in contacts to the urgent primary care service. I think we need to do a bit more work in just understanding the sort of the outcome of those contacts. We have seen a reduction in the ambulances that are waiting over an hour, quite a significant reduction from 1,500 in March to 1,285. Again, slightly off trajectory, but huge improvements made there. And our delayed pathways, so our delayed discharges are reducing in line with the commitments we made in the plan as well. So whilst there have been some challenges, we made good progress in delivering on some of our commitments we made around Q1 performance. I'll pause there because I'm sure colleagues that have got queries on some of the detail in there, but happy to take comments or questions on the report itself or on the actual content of the report.
Thank you, Hannah. That's very clear. Are there any questions or comments on the performance report?
Reads very well.
But there are big problems to sort out, aren't there? What's the feedback from Welsh Government on our performance at the moment?
They're pushing us. They haven't had the recent conversations. I think they recognise what we said we were going to do, we're delivering, which is always bonus, but they're pushing us to go further and faster, but recognising the challenges across the system. I don't know if you more recently had a meeting with Welsh Government in terms of the COOS meeting last week.
Yeah, Nick's put in a monthly meeting with us directly. They're meeting directly with COOS on planned care delivery and their expectations. So we've had our first meeting last month is a follow-up on Friday. We're hitting the milestones as Hannah's already said, and I think there's recognition of the work and progress that we've made, and we're trying to isolate and push teams and services sort of to deliver outside of those difficult specialties, so we're continuing to drive that agenda. Cancer, there's been a recent meeting on cancer, and actually we're performing pretty well, sort of 62% sort of is an update, more recent sort of position. And actually even those health boards, I think, that are perceived to be doing very, very well from a cancer perspective, we're actually, nipping at their tails, for want of a better description. There's a real, I think, sea change in terms of the cancer team that we've got now, sort of targeting and focusing improvement, and we have recognition of the pathway work that was being done and the transformation piece, so it's not just more of the same. So I think generally there's no acceptance from the teams that the status quo is acceptable. There's a continued push for improvement, recognising the position we're in is where no one wants to be, but cognizant of the challenges and difficulties that we've got. Some of those services only receive their capacity is eaten up with cancer and urgent referrals. So I think understanding that is really, really key. But there's more that we can do for sure. But Welsh Government, generally speaking, I think, I'm not sure content is the right word.
Yeah, because we certainly just received new guidance on managing people on the urgent cancer pathway, haven't we? So we have to consider how that affects the way in which we can manage.
We also just if it's okay, just to add to that, we had a planned care programme board meeting earlier this week, and we're not losing. I know it's come through me, I think some of the MS or MP letters, how we can further strengthen. So whilst we're focused on getting the lists down, what we can do to better communicate with those waiting, both in terms of keeping well whilst waiting, but actually being open and transparent about the wait. So there's some work that was there's information already accessible through some of the national resources, but some work initiated just to review that and see what we can do to further improve it and then signpost people to it. Yeah, thank you.
Phil?
Just a reflection really on the report. I mean, there's a lot of detail in there. Sometimes it's hard to work out whether we are good, bad or indifferent. And I just wonder whether we ought to have something in the table that would say, well, best in class for this is here, maybe Welsh average is here. It would actually paint a different kind of picture for us, because I've read it once or twice and it reads okay, but you think, well, is that really good, or is it better than not very good? You know, it's difficult to gauge it. It's just a
that's helpful feedback, as I said, as we continue to strengthen it. And it's a bit to the point that Tracy was making earlier is, it's helpful to know where we are in Wales, but we should be aspiring to be the best in class upper quartiles across a wider comparative.
Just on that point, really, so I think it's right, we talked about where to compare, but getting to best in Wales as a start, and then go broader. And there is a useful dashboard. Some of the key indicators are shared it, and we've done quite a bit of work with the executive team where we you do understand where you are and you rank in the 6 big health boards, kind of where every month I look at where we are, and we've looked at how we incorporate, and I think it kind of needs to sit alongside it, because if we get a little bit reassured by doing this about where do we want to be and we're on track, but I think the two together is important. I think it is this delivering what we said we were going to do or what we want to do, and then how do we compare in the wider context? So I do think it's a really helpful, and maybe we can think twice a year, where we try to put it into the narrative, but it is something I've picked up about how we systemize it. And the other thing and I picked up on David's point at the last board meeting, is how we look at on urgent emergency care in particular, to put in like an easy infographic together that we could share each month with some of the metrics everyone becomes familiar with, which I think would also be useful for yourselves in terms of keeping yourself updated, so that when you come to the meeting you've had quite a good, and how could we perhaps do that for planned care cancer, those really big high profile areas. So we follow that up as well. But we're going to do urgent emergency care first, maybe we can test that. Maybe we could put the comparison there then.
Yeah, that'd be good. Thank you. Shelley?
It's just a similar point really in terms of the reporting, because where you've got some sort of improved or same, which, and then you've got deteriorated, and you tend to focus on those. But I suppose sometimes I look at, say, the 4 or 5 in that area, and I'm actually not really sure which are the key ones, which are those. I know we want to do them all, but if we have to focus, so what are we focusing? Is the deteriorating metrics that we're using actually the one that we really should be focusing on? So it's about that, the nuance between that. That's something that I struggle with.
I'd agree, and it's then being clear in the narrative what we're doing about those deteriorating, and I think we can do more to strengthen and
there, but it needs to be
make it much clearer about what the recovery, what the improvement actions are, so it sort of hits you really, and you're either assured or otherwise on that.
Yeah, thank you. Any further questions? No? If we can move on to the financial performance, and bear in mind that we will have a discussion about financial performance in this section as well.
Thanks, Anne. So the report that's been circulated, due to timings of putting together the numbers, is the month 2 report to the end of May this year. In terms of the highlights, in terms of the revenue position, you're reporting a year-to-date earnings of £29.4 million. That's compared with the IMTP plan profile of 24.5, so we're 3.9 million off our expected revenue position. Bearing in mind that we did actually set an IMTP plan with a £112 million deficit forecast, so that's what our budgets have been set on. In terms of capital, we've spent £6.2 million in the year to date. I'll come on to forecast in a moment, but there's risks around that to pick up as well as the revenue. In terms of our public sector payment performance, that's how quickly we pay our suppliers. We're achieving in excess of the 95% target at 96.4%. And in terms of our cash holding, we were holding 4.7 million at the end of the month, which is within the £6 million advisory figure we've been identified. So that's a review of a very quick highlight review of the year to date. And the dashboard on the first page will show the RAG rating of that. If I can move on to forecast before I draw some in-year points out. So in terms of the forecast we've reported, and we've reported to Welsh Government as well as to the board now, it's £112.8 million, which is our IMTP forecast plan. We've held that, but there is more work to do to make sure we achieve that. Significant risks, and depending on the steps we take next, we need to mitigate from where we are now by about £40 to £50 million. But I'll come on to that in a moment when we talk about savings. But there is significant risks to achieving that forecast. So I'll leave that there as we'll pick it up in the committee section. In terms of capital, whilst we are within our current spending limit, we are forecasting a £2 million deficit. Now, we are managing that currently by deferring some of our discretionary schemes, which is obviously an opportunity cost to us in terms of some of our priority areas. We are hoping that some of the costs that are driving that overspend, which are significantly generated through nationally funded programmes, that we will get some recovery from Welsh Government on that, although that's not come to fruition yet. So depending on where we find ourselves, what we need to do with capital, that could be a balanced position, but obviously an opportunity cost for us. In terms of the forecast position, Hannah's undertaken a review with the service around proposals for prioritisation and reprioritisation of some of the bids come forward. So hopefully that will have an impact in terms of mitigating some of that. In terms of the year-to-date position, I would just pull out a few key points. So the income assumes that we, or reasonably assumes that we will receive funding for the wage awards, which we've been informed we have, but we haven't actually received it yet, so that's anticipated. In terms of our overall costs for pay and non-pay, I just repeat some of the reflections of earlier in the meeting, that our particularly urgent care and other operational pressures, along with delayed transfers of care, are continuing. We're not seeing significant change in our operating pressures, as well as our need to deliver the performance targets that we've undertaken with Welsh Government. Having said that, in terms of pay spend, while pay spend has increased, the majority of that is to do with pay award, which is funded. So the actual key points to note is that we are seeing a change in our model of pay delivery from high cost agency through to enhancements and bank, but we are still using a significant amount. In terms of off-contract, there's a huge reduction in use of off-contract agency, and as alluded to earlier, enhanced care has improved quite a lot as well. So the change in our delivery model is reduced on a unit cost basis, but we are still using quite a lot to cover vacancies and deal with demand we're facing. In terms of a non-pay spend, we've seen an increase in there. That's across a lot of areas. Most of them, in terms of a step change between April to May, are funded, but we are continuing to see pressures, which we've discussed previously, around particularly prescribing, continuing healthcare. Energy has reduced, which is a positive for us, but that's volatile, so we need to keep a watching brief on that every month, which we do automatically. But our operational costs continue to be at significant levels, which are challenging the delivery of our forecast currently. In terms of savings, the 112 forecast assumes that we do achieve all the savings we put in the plan, either through the plan mechanisms or other mitigating actions being taken. Currently, our green and amber savings come to £21 million, and we are assuming they are included in the amber, which is for note, are going to be delivered to support the position, but also then there's approximately £29–30 million of red RAG rated schemes, which include not just cost reductions, but potential income slippage, receipt of certain income for and allocations for some regional work to effectively create that £51 million figure. So we do need the red rated schemes delivered or alternatives found. In terms of delayed transfers of care, moving on to some of the operational issues. So at the time of reporting at the end of month 2, we continue to have significant levels of delayed transfers of care, 283, approximately 50% due to social care reasons. But if you take that 283 on a marginal bed day cost, that's about £20 million cost pressure for the year if that continues. Elective activity continues, particularly in terms of trying to achieve our performance commitments, and that's delivering broadly in line. We've had, which I'm sure the board will remember, we've had a flood in the ophthalmology department, which has caused a blip in delivery, but hopefully that'll catch up. And in terms of capital, as I say, the forecast is driven by national schemes overspending for various reasons, inflationary pressures, some delays in delivery, and we're hoping that the Welsh Government will support elements of those cost commitments to allow us to free up some of our discretionary funds. I'd probably leave it there for the moment, Anne, unless there's any questions, and conscious we'll pick up a brief on month 3 in the in-committee section.
Thank you. Has anybody any questions? I think I'm very concerned about the savings. I mean, even to make those savings is not going to get us where we need to go.
No.
And I think that, you know, we will have to have a very wide range and serious talk about how we are going to manage the resource in an effective way. And I know huge strides have been made. We have to say 50 million before. Mind you, we've never been overspent like this before either, by any stretch of the imagination, but I don't think any of us are in any illusion that we are going to have to go further and faster. The Minister has called Nick and I in this morning to meet her tomorrow about the financial position. So it's obviously escalating within the ministerial ranks as well. And I think that we as a board have got to have absolute confidence and assurance that we will be able to achieve a better outlook than the one we've got. A huge amount of work's gone on already, which is clearly outlined in this report. But, and I know the finance director doesn't spend the money, but there is further that we will need to be going, and we need to have the confidence that we can make those decisions as a collective board. Nicola?
Yeah, so I completely agree the significance of this, and you know, the plan and the 112 million deficit is not, you know, acceptable, let alone when we're off plan, as we are. Our spend if we continue to take us way beyond that. So we've got some further sessions planned this week. We've had again a dedicated session last week. Leanne's working with the divisions. You know, as part of our delegation, we will be expecting each division to come up with what does a break-even plan look like for them in terms of getting to live within their allocation as it stands, and what are the choices and options we've got in order to get there. So we make sure we do that through our delegation, as well as doing our kind of corporate overview of options. But ultimately, first is to make sure that that ownership is at the divisional level, you know, which I think it is, but what are those options, what are those opportunities, what are those difficult decisions we might need to make so that it's owned at that local level, and then we can take that organisation. So we do in the both sides of it, but with more work, we get a kind of regroup tomorrow following last Friday's session, where we had a really good debate with our senior leadership teams around, you know, what are some of those things we would stop doing first, what things can we use better over time. We've also done a trawl of all business cases that are in development somewhere, and are taking a really firm line to say stop doing them all, because we haven't got the money to do them anyway, unless they meet some specific criteria around urgent safety issue, or they can help make us more efficient or save money. And everything else will kind of be paused until such point where we're into next year's IMTP. Or so, and again, it gives the teams more capacity to spend their efforts on the things we need them to, than spending their time on a business case that's not going to get approved, recognising. And again, the other thing we've talked about is the communication through the organisation around making sure everybody knows about the challenges we're facing and the importance of, you know, making sure we really are all working towards the same position. And that is difficult because we've had years of having financial difficulties, and that it is getting, how do we get the message out that we are in different territory now? So that's something we've also talked about tonight. I've got a communication due to go out, and again, asking staff and teams to come forward with ideas if we've not already thought of them, or they just want to, you know, people can put anything forward if they need to. So there's a few things happening, and we're also making sure, so some of the work the Welsh Government have identified, and you know, the likelihood in terms of where we could end up being in escalation is that we are content that our control environment is robust, and there's nothing we're missing, and if it is, how do we strengthen that? So we're also doing that check as well. Thank you. Any further comments?
Really, from our perspective, you know, sat around the table here, I think there's something about value for money decisions that we just need to make sure that we have that clarity when things come in front of us, that's something that's been considered as part of the paper. You know, I think, you know, Nicola's right in terms of sort of how we close down on things, that we must do the things that result in the best care for our patients. But you know, it's the bells and whistles sometimes that we won't be able to provide. But I think if we find when we get papers that they've got the information that we need, that they've considered the value for money and quality and patient quality within that, I think that's really helpful to us as well. So
thank you. Yes, I'd agree with that.
Paul?
I think there has to be a reality that we have to be within budget. We're already 3 to 4 months, coming up to the 4 months into the financial year. Now that to me means that we've got 8 months left, and we could be looking at savings of what, 10, 12 million pounds a month to try and overcome this. So I think we've just got to understand that it's a huge challenge, and what we've got to do as a board is to ensure that by the end of the year we meet that challenge, because part of our duty is to ensure we work within the budget. And therefore, what can we do to help the executive team to be able to realise that sort of figure? So what can we do to help you, Nicola, and the team to try and address that challenge? Because ultimately, you know, we are responsible as a health board. Part of our auditors, when I was at the committee yesterday, was we've got, they say you're not going to meet the challenge. And I mean, we have to say to all of us have to accept responsibility. It is a challenge, but we have to address it. And do you think, I mean, you know, having conversations with people, fine, but that's not going to get £15 million a month or £12 million a month. I'm just trying to think what radical solutions or options are there on the table for us to consider to be able to address what is a significant problem. 100 million, 120 million pounds, 112 million pounds deficit. I mean, what radical options are there? Because I think we are at that stage.
Yeah.
Sorry. So, in terms of the risk that we're currently reporting in the board report is to get us to the 112. So Welsh Government in the round, as a minimum, have asked all health boards to hold their forecast positions or do better. So whilst we haven't got approval for that 112 deficit, that's, if you like, our minimum expected delivery. And the risk we've got at the moment, and what I was alluding to, as part of where we're finding ourselves now, is beyond that. So there's about, come on to it later, but there's about the order of 40 to 50 million pound we need to try and secure. So your numbers are actually quite right. It's about 11 million pound a month going forward, about 8% as a run rate we need to reduce to the end of the year to get where we need to be.
So I think it's probably getting out to those sorts of figures of saving how much a day we have to save effectively. Talking about figures, because that's what we're looking at. And I think that would be helpful to staff to be able to think, well, okay, how much are we thinking about? And that's when it comes to teams to think, well, we've got to save that sort of figure. And I think we do need to have a reality check, and I think we have got a responsibility to achieve the savings, and we have to look to you to give us advice and support and evidence of the radical solutions for us to then support the decisions.
Yeah, and thank you, Paul. And that is something that is part of the comms I was just working out yesterday, and I've been speaking to people, is we spend £5 million a day in the health board. We need to spend about 4.5.
Right.
So it depends which figure you want to take, the 112 or the 0, but it's, and then it was almost like it's £26 a day per person. It's trying to turn it into, what equates to £26? What's 1 hour of lighting? What's, a group of consumables? I don't know. So it's all about trying to turn it into, I think, get some sound bites that make sense to people on the ground in terms of the contribution they can make. But that is the number. We're running at probably between £200,000 to £500,000 a day more than we can afford, depending on which number you want to take.
Right. Well, I think that's helpful because it does bring it down to sort of simple figures for people to understand, because these vast figures, people think, well, that number is beyond us, but actually we've all got, I think we're all in it together. And I think that's what we've got to re-emphasise, that there's no bailout on this occasion. This is about us having to keep to the budget, and we have a responsibility to do that, because ultimately, if we don't, then there's all sorts of problems for all sorts of services if there's intervention of any kind.
Okay, thank you. Okay. If we can move on to the strategic risk report then, please.
Yeah, thank you. As you're aware, we've had quite a number of board sessions on reviewing our risk management framework and a kind of refreshed approach to strategic risk management. Ronnie's obviously taken a key lead in leading us to this point, and we gave an update of the framework at the last meeting. So we've now set out in this report kind of the key 8 strategic risks, and then a subset of risks that sit within there, really picking up kind of that those sessions we had in terms of understanding the difference between risk and issue, and then some of the cause. And what we've now got to do is the next steps around each of these kind of 8 risks and the 18 subsets in terms of the key milestones, mitigation, timescales, likelihood, all of those. So this is kind of the first step in that piece of the next step in the piece of work that we've been developing. It kind of makes a lot more sense to us as an executive team since we've been doing it, and really helps you understand in terms of the risk and then some of the sub-risks, and then what could it result in. And sometimes our risks will the what it could result in bit when you kind of look back. So hopefully it makes more sense. As we said, we've done the risk scoring, but it's now about the mitigation and likelihood, and then the method with which we monitor our progress against each of these risks on a regular basis. So welcome any comments, views, and hopefully reflects some of the discussions we've had. And we've also put in there the old risk register and how they've been transposed over to the new risk register, so we are confident we haven't lost anything as part of that new approach. You wanted to add, Ronnie?
No, thank you.
Shelley?
Sorry. No, I think this format, I agree with you, the risks are much easier, and where the sub-risks risks say anything. I was just saying, in terms of reporting, I don't know, are there target dates for these? Are there target dates for risks?
No, not yet. So we need to develop mitigating actions, timescales, etc., and then map that against the work that we're doing a lot, appetite, etc. So that'll be the next phase of. So we've got the risks. We're clear about the level of risk, and then the detail that sits alongside that is next.
I know perhaps I should know this because you probably told us, but sort of what's the time scale for that? Are you talking about sort of by the end of this?
Yeah. So the next board meeting, you should see a more comprehensive risk assessment for each risk, and then but the evolvement of that in terms of assurance framework, etc. I think will take some time. That's fine.
Okay. Any comments on the risk register, Ewan?
Just to confirm then that these risks will be managed within each of the individual committees, or not managed, or reviewed.
Yeah. So yeah, and they should be easier to map to committees in terms of the way they're structured now, and the assurance elements will be key. So when we've done those board development sessions, the conversations we've had about seeking the board and committee seeking assurance on the effective management of the risks rather than the detail of the mitigating actions. So we just need to do some work about developing that frame of reporting. Yeah, but we're at the start of the process.
Yeah. It's much clearer. It is much clearer. Yes, well done. It's a much clearer overview of the strategic risks, and we look forward to seeing the next version with the mitigation in the timescales. Okay, anything particular on any of these risks that people need elaboration on? No? I know they've been discussed by the relevant committees anyway, haven't they? And you always bring things to our attention. The Executive Committee Chair's report then, Nicola.
Yeah, so just some very brief headlines. This report's self-explanatory, very busy first quarter, as you can see. Just pull out some key focus on quality, safety and culture element of the agenda. I wanted to just particularly draw out the outcomes report, which Hannah referenced, so the work we're doing around quality outcomes development, that kind of focus on quality improvement. Again, I think just gives us all the right focus on things. And then just pull out the ward accreditation that we piloted in Ysbyty and Aneurin Bevan, and looking at some learning and experience in England and where this can really raise the bar between wards and really try to empower the ward team. So really important piece of work that we're quite keen on, rolling out across the whole organisation. Under the delivery, performance and efficiencies, I just wanted to pull out the work. We talked a lot, didn't we, in the various board meetings and sessions around mandatory training, a different requirement for different skills. So we have now set up, and say it's mentioned in the people plan, this kind of core learning committee, which we're going to kick off now in the next month, but really look at all the training requirements and make sure that we've got a coordinated approach to all these requests and requirements. And I know we mentioned the medical e-systems, but we have now allocated the contract and awarded the contracts. So hopefully we're on track for getting that kind of job planning, which we know is a key priority for us. And then briefly in terms of the strategy planning side of things, we've had a really helpful session. Tracy led with a kind of fresh thinking around population health and prevention, and really trying to embed Tracy's fresh perspective in our business, which keeps challenging us on concentrating on the here and now and that big prevention piece. So that was a really helpful session with more planned. And I think it's also worth pulling out, we did follow up on the Primary Care Academy and felt this was a really important investment to avoid new costs, and as part of our longer term investment to reduce locum costs as well and have a sustainable workforce. We had a really helpful time out session then. We still have one session a month, which is some more kind of thinking time, and we had some colleagues from England come and share some of their experiences on the big culture piece, the big focus on quality, and really in terms of helping us think about that strategy refresh, the culture issue that we talked about earlier. And it's something that we kind of going to reflect on tomorrow, but would like a session with the board at some point in terms of how we do this kind of together. But really some helpful learning from England, particularly some of the work they did about ward accreditation, some work they'd done on bereavement was really helpful, but all of it was about changing culture and a focus on quality improvement. It was really helpful for us just to think about a different way of working in the health board. So a really good time spent for us as a collective team. But lots more in there. I'm happy to take any questions.
Thank you. And I think a joint session with the board would be very helpful indeed. Any questions to Nicola?
Well done.
You're all very busy. Yeah.
Very busy.
Joint committee activity?
Yeah, there was the reports. There's nothing because the last meeting gave the most updated report. The meetings were held yesterday. Rob attended WISC and Jenny attended Summer East because we were delayed with a complex complaint. But I've looked at the WISC notes. I think there was nothing of significance to report other than a continued focus on performance in terms of the LTAs.
Yeah.
An ongoing discussion. There were some specific issues which we can share in detail at the next board meeting.
Okay.
I'm not aware of Jenny of anything in East. There was a particular not that significance other than the normal focus on performance and the development plan around the local ICPs they called, are they, the local groups. We have in the meantime met with WASC in terms of trying to work directly with WASC, conscious of our previous session with EASC. So we followed up following our session with EASC, and we've also met with WASC as a couple of exec directors just to make sure we've got a robust working relationship to deal with some of the tricky issues that we pick up between us.
Thank you. Any questions on that note? 5.12, key matters for committees of the board. Is there anything the committee chairs would wish to bring to our attention in particular?
I did highlight that we were short on equality champions, being naming them from the exec end, but I've been reassured by Sarah that this is now underway. I think it's okay. We've got the whole which role within the champion.
Fine. Thank you. Ewan?
Yeah, the report that's in there is obviously from May. We had a meeting yesterday. All the financial accounts, etc., come here today. The only thing that wasn't mentioned in that was that the overall internal audit opinion for the year would be a reasonable one.
Oh, good.
So they confirmed that yesterday as well.
Yeah, I think it was included in the note.
Sorry?
I think it was included in the note.
Oh, was it? Oh, sorry. Yeah.
Charitable funds, I just wanted to say that I think just to re-emphasise to the executive team, there are funds available for particular projects, just to bear that in mind in this time of sort of when there are some issues and problems, then the charitable funds is a committee which considers applications based on criteria, etc. But I think it's just that that's available.
Thank you, Paul. Anything else? No? Well, the date of the next meeting is the 27th of September. And we will now the members of the press and the public. We will go into our confidence session.